So should we start or should we wait for the others to join?
I think we should start.
Okay, I'm sharing your screen. Okay, so today we will cover physiology. Yesterday we covered anatomy and embryology questions of UWorld of uh, of pulmonology section. And today we will cover the physiology section questions. Okay, so we will start with the first question. Okay. Which respiratory physiologists conduct a study to assess the airway resistance of a lower respiratory tract in a healthy volunteer. During the experiment, they measured the total cross-section airflow resistance as it changes between each airway generation. Which of the following graph is the most likely to be observed in this study? Okay. Can anybody tell me where is the highest resistance in the airway resist in the whole of the airway tract?
Medial bronchi.
Medium-sized bronchi. Okay. So why it is highest in the medium-sized bronchi? Okay. So the resistance depends on what? The greater the cross-sectional area, the lower is going to be the resistance. The larger the pipe size, the less resistance will the water will face when it is moving through that pipe. Okay. Now open your first aid. I will let you know the page number as well. Where it is written. I think so. I should, instead of telling you the page number, I should open my own first aid and let you see the paper where it is exactly written. Need to written somewhere. Oh, okay. Okay, so you can see in the second line, airway resistance is highest in large to medium sized bronchi on page number 680, anatomy section, conducting room. Okay, so the airway resistance is highest in the large to medium sized bronchi. Okay, so in this graph, which option should be the right answer then?
D.
D, yes, because it is highest in the medium-sized bronchi. In option C, it is lowest. In option A, the highest resistance, in option number A, the highest resistance is in trachea. In option number B, the highest resistance is in terminal bronchioles. In option C, the highest resistance is again in terminal bronchioles. In option D, the highest resistance on the y-axis is in medium-sized bronchi. Okay, so option D is going to be the right answer. Okay, see, option D is the right answer. Okay, so because the greater the total cross-sectional area, the lower is going to be the resistance. The terminal bronchioles, each if you are taking only one single terminal bronchiole, that has a very small area. But if you collectively take all the terminal bronchioles and combine the total cross-sectional area of all the terminal bronchioles, that will be very high. That's why the terminal bronchioles has the lowest airway resistance. Okay, and the medium-sized bronchi have the highest surface area resistance as compared to trachea. Okay, so remember this. It is not like a straight decrease. There is a first increase and then there is a decrease. Okay, medium-sized bronchi has higher resistance than trachea. Remember this difference. Okay, let's move on to the next one.
Excuse me, Doc. By chance, you can make the screen any bigger?
You want me to make skin bigger? Is it okay?
Yes, the screen is minimized, so we can hardly see the questions too.
Can
Maybe
you
because you're using your
rotate your
phone.
cell phone?
So today I have only my cell phone. Is it? Can you see? Can you see now?
When you use a cell phone, that's the biggest the screen could be. So that's the
Yes.
problem.
Yeah, but
Okay.
I can zoom in. If anyone is like me, you can just zoom your screen and it will be big.
Yeah, you can try zooming in your screen.
Okay, doc, you can continue.
Okay. Okay. Now comes to the second question. Always start from the last line. Which of the following is the most likely cause of this patient's symptom? Then give a read to all of the options in 5 seconds. Okay. Now comes back to the question. Okay, so we are seeing a graph of normal patient lung volume transfer information. A 43-year-old Okay, so can you tell me the area under this graph represents what? Represent what specific thing? Lung volume over change in lung volume divided by change in pressure is equal to.
It's equal to
Like
compliance.
Yes,
compliance.
Equal to
change in
compliance.
okay. So change in lung volume over change in pressure is equal to lung compliance. Okay. So in the patient, the area is lesser, the area under the curve is lesser than the area under the normal. Is it lesser or is it higher?
It is
Less.
lesser. Lesser.
It's it
Lesser.
lesser. So that's mean compliance is
Low.
decreasing, right?
Mhm.
Decrease.
Okay, so when the compliance decreases, that means that the lungs are now much more difficult to stretch, right or wrong?
Yeah,
Yeah,
Yes,
yeah.
sir. Yes.
now you need a much larger force to stretch the lungs. Okay, it's kind of a fibrosis thing that the lungs become much more stiffer, much more harder. Okay, okay. Now open your first aid on page number. Okay, on page number 683, the compliance. See, this is the same photo which is in the question. On y-axis, you are seeing volume. On x-axis, you are seeing the pressure curve. Okay, and when you want to see what these graphs represent, just divide the two things. Volume over pressure, you will get the thing, whatever that thing is trying to represent. Divide the thing which is on the y-axis by the thing which is on the x-axis. Okay, and we know that the formula for compliance is delta V over delta P, change in lung volume for a change in pressure. It is inversely proportional to the wall stiffness. Increased compliance means lungs are easier to fill. Decreased compliance means lungs are harder to fill. Okay, and in fibrosis, in pneumonia, in edema, and in ARDS, lungs are much more harder to fill. Okay, and see this graph. The red line represents the fibrosis line, and the red line, the area under the red line is lower than the area which is under the green line, which is the normal one. And emphysema, and emphysema line, the blue line, that curve has an area which is higher, okay, than the normal line. Okay, that's mean that the compliance is increasing in the emphysema and it is decreasing in the fibrosis. Okay, so now you have to tell me what should be the answer of this question. Okay, now I am moving back to the question. Now you people know that the person has the person compliance is decreasing. Okay, so which should be the answer then?
Pulmonary
Pulmonary
fibrosis.
fibrosis.
Pulmonary
E1.
Pulmonary fibrosis.
Yes,
E.
pulmonary fibrosis. See, now the
Fibrosis.
question, yeah. Now, once you read the first aid, the questions become much more easier. Okay, so bronchial asthma is an obstructive lung disease. Alpha-1 antitrypsin deficiency is an obstructive lung disease leading to the emphysema. Idiopathic pulmonary arterial hypertension has nothing to do with compliance. Okay, fibromyalgia has nothing to do with compliance. Okay, see that curve, the emphysema curve. is higher, fibrosis curve is lower, same as in the first stage. Okay, so reduced compliance, pulmonary fibrosis, emphysema, increased compliance. Okay, let's move to the next question. Which of the following is most likely increased in this patient? Okay, function. So most likely we have to first diagnose the patient, and after that we have to tell which of these following a value is going to increase. Okay, now let's try to diagnose what is the main pathology in this question. 47-year-old man comes to the emergency department with 30-minute history. First, when you're trying to read the question, try to find each, do not skip any abnormal finding in the question. Okay, and then try to find the answer which can explain each and every abnormal finding in that question. Okay,
Hey, Margaret, can you mute your mic? It's like very noisy.
so what is the diagnosis here?
Pulmonary embolism.
Yeah, because of DVT. It's the pulmonary embolism because of
Yes.
DVT.
Okay, so yes, first he's on a road trip. Okay, remember whenever you see a patient of a, most likely the person is on a very long flight or on is a truck driver or something like a very long road trip. Because what happened in road trip, you are not moving your legs, and this is one of the which you tried DVT, stasis of blood. Okay, let me show you where it is. Okay, let's open pulmonary DVT. Okay, so see, in virtue triad, there are three things: stasis, hypercoagulability, and endothelial damage. Okay, so since stasis usually on post-op and long drives and flight. Okay, so and DVT is the most common cause of pulmonary embolism. Remember, okay, and how does a DVT patient presents? Swelling, redness, warmth, and pain. Okay, and now comes back to our question. He's on a road trip with his family, and he has a pain and swelling of the left leg for the past 2 days. Okay, now comes to the complication of that DVT. The most common complication of DVT, pulmonary embolism. The patient develops sudden onset dyspnea. Remember, whenever you see sudden onset dyspnea, tachypnea, and tachycardia. The first thing that should always come inside your mind, it should be pulmonary embolism. Remember this. Sudden onset dyspnea, sudden onset. Hypoxemia, tachypnea, what is the respiratory rate here? 32. What is the heart rate here? 125. Okay.
124.
Can anyone explain why the blood pressure is 90 by 56 here? Can anyone explain why the blood pressure is 90 by 56?
The patient is going in shock.
Yeah, it is obstructive shock. It is a massive pulmonary embolism. Okay,
Yes.
that's why it's 90 by 56. Usually, you will not see such a big drop. In 99% of the pulmonary embolism cases, you will not see such a drop. Usually, the blood pressure is not drop like this. Okay, but when there is a massive pulmonary embolism, like a saddle thrombus or something like that, you will see such a big drop. That can happen in pulmonary embolism. Okay, so most of people when they see this, they think that it is heart failure. But remember, on ECG, there is sinus tachycardia. There are no signs of STEMI or anything like that. Okay, and chest X-ray is also normal. Pulmonary embolism usually does not show any signs on chest X-ray. Okay, okay. Now we can explain all the findings in this patient through pulmonary embolism. Okay, now comes to the second part. We have solved the 50% of the question. Now comes to the remaining 50%. Which of the following is most likely increased in this patient? Functional residual capacity, lung diffusion capacity, physiological dead space, total airway resistance, or pulmonary compliance? Okay, so we will start from each options. Okay, first we will start with functional residual capacity. Does it affect the functional residual capacity?
No.
No.
No. Why it does not affect the functional residual capacity? What's the reason behind it? On what factors does the functional residual capacity depends upon?
Functional residual capacity depends on like residual volume and like expiratory reserve volume, which does not change in
Yes.
this because vessel is closed in this condition.
Okay. Okay. And now comes to option number B, lung diffusion capacity. Okay. No. So lung diffusion capacity, does it going to affect the lung diffusion capacity?
Again, no.
No.
Again,
Because of
no.
the decision, yes.
Why? Yes, because diffusion capacity depends upon the alveolar capillary interference membrane. When it is going to be thickened, like in pulmonary fibrosis, or when it is going to be the surface area is going to be reduced, like in the emphysema, then it is going to be affected. Anything which is going to directly affect the lung architecture, that is going to affect the lung diffusion capacity. It will never be going to be affecting the pulmonary embolism. Okay, now comes to the pulmonary compliance. Okay, same thing in the pulmonary compliance. It depends upon the lung parenchyma because it does not affect the lung parenchyma. Like if you see in pulmonary fibrosis directly affect the lung parenchyma. It's it makes the lung parenchyma much more stiffer. Pulmonary emphysema directly affects the lung parenchyma. Okay, so pulmonary compliance is also not going to be affected. Total airway resistance. We know pulmonary embolism is a disease of blood vessels, not the airways, right? It is not going to cause the blockage of airways. Okay, so what do we are left with? Physiological dead space. Physiological dead space is going to be the right answer. Okay, now let me show you. Here it is written in your first aid. In your first aid, okay, on page number 685, VQ mismatch when the Q stands for perfusion. When Q becomes zero, we know whenever the denominator becomes zero, the answer is going to be infinity. 10 divided by 0, infinity. 20 divided by 0, infinity. 30 divided by 0, infinity. Okay. So blood flow obstruction. Okay, blood flow obstruction leads to physiological dead space. 100 assuming 100% dead space, 100% oxygen improves arterial oxygen ratio. And what is the example? Pulmonary embolus. Okay. So blood flow obstruction increases the physiological dead space. What is the dead space? It is the dead area which is not taking part in the gaseous exchange. Why that area is no longer taking part in the gaseous exchange? Because now the blood flow is not there. So how you are going to exchange the oxygen and carbon dioxide in the air? Because no longer that specific area in which the blood supply is obstructed, the air in that specific alveoli will no longer be able to participate in the gaseous exchange. So it is going to increase that space. Okay, that space is the area which is not taking part in the gaseous exchange. Okay, and blood flow obstruction increases the physiologic dead space. Okay, it is written in your first aid as well. Okay. Okay, let's move to the second part of this question. Let's see. Okay. See this photo. In the first alveoli, there is a ratio of 104, and in the second two, the oxygen ratio remains 150. Why it remains 150? Because now the oxygen is not delivering into the vessels. That's why it's remain elevated in the alveoli. Okay, because the blood flow is obstructed there. Okay. Okay. Let's move on to the next one. If No, not the second part. Okay. Which of the following breathing patterns most likely be contributed to this patient change from the left bar to the right bar? Okay, now we have to tell which of the changes are going to occur from the right bar to the left, from the left bar to the right bar. It is the continuation of the previous question. Okay. During evaluation, the beginner present developed cardiovascular patients. We have put the patient on the ventilator. Ventilator after the ventilation, the following changes are noted on the diagram. Dead space ventilation is shaded in the black area. Okay. Okay, which of the following pattern most likely contributed to the patient change from the left bar to the right bar? Okay. So the y-axis represent the minute ventilation. Okay, there is minute ventilation. Okay, so first tell me, does the total height of the two bars are equal or not?
Not.
No.
No, if you
Equal,
combine,
equal.
yeah, yes,
Yeah.
if you combine the black bar plus white bar, the total height,
Yeah.
yes, that
Yes,
means
equal.
yeah.
Yes,
So
Total height is equal.
total height is equal. Okay, now comes what is minute ventilation? Okay, for minute ventilation, let's open first aid. Okay, that is minute ventilation. Total minute ventilation is the total amount of gas which is entering the lungs per minute. What is it is abbreviated as VE. Okay, let's see. It is abbreviated. Let's see the highlighter. Okay, so it is abbreviated as VE. Total amount of gas entering the lungs per minute depends upon two factors, VT and RR. VT is tidal volume and respiratory rate. It depends upon these two factors. Okay. So because the total height of the two bars are equal, that means the amount of air that the person is taking in both of the cases, in a minute, amount of air that the person is taking in a minute, in both of these scenarios is going to be equal or not. The minute ventilation in both of these scenarios is going to be equal or not.
Yes, equal.
Equal.
Yes,
Equal.
yes.
Equal.
So now we have come to the conclusion that the total amount of air, like if the person is supposedly taking 1,000 ml of air inside his lungs, okay. So the other person is also taking 1,000 ml of his air in a minute, okay. So what is the difference here? We can see that the ratio of black box as compared to the white box is different in both of these large boxes, right? Okay, and we know that it depends upon two things. We have just seen one is respiratory rate and the other is
Tidal volume.
tidal
Tidal
volume. Our patient is suffering from what?
Pulmonary
Embolism, pulmonary embolism, right? What happens to the respiratory rate in pulmonary embolism?
Increase.
Yes, yes,
Increases.
yes. Respiratory rate increases. The patient goes into tachypnea. Okay, and when the respiratory rate increases, we can see the black box represent the dead space. Okay, we see that dead space is increased. So the respiratory rate is increased. Tidal volume is going to be the other white box is smaller. That means the tidal volume is going to be small or high. Yes, tidal. Yes. Because tidal volume is going to be small. Respiratory increased respiratory rate is going to be compensate for this. See this like let me give you an example. One person is taking one breath in a minute and is taking in 1,000 ml of air inside it. Okay, he is taking one breath each minute and is taking 1,000 ml of air inside his lungs. Okay. And now compare another person. He is taking 10 breaths per minute, but he is taking 100 ml of air with each breath. Okay. Is the minute ventilation in both of these scenario is going to be same?
Yeah.
No.
Yes.
Minute
Yes.
ventilation will be same.
Yes, minute ventilation is going to be same in both of these cases. 10
Yeah.
multiplied by 10, 10 multiplied by 100 is equal to
1,000.
1,000.
1,000.
Yes, 1,000 multiplied by 1 is equal to 1,000. Okay, so the right answer is going to be respiratory rate increased and the
Tidal volume
volume
decrease.
decreased.
Volume decrease. Yes. B.
Yes, B is the right answer. C. C is
Doctor,
try
can
to
you
see.
please explain again? I did not understand.
Okay, okay, I will try to explain this again. Suppose there is one person who is taking one breath in each minute and he is taking in 1000 ml of air. Okay, so in each breath. Okay, so his tidal volume is 1000 ml. His respiratory rate is going to be 1. Minute ventilation is equal to respiratory rate multiplied by tidal volume. 1 multiplied by 1000 is equal to 1000. Now suppose there is another person. He is taking in 10 breaths per minute. And with each breath, he is taking in 100 ml of air with each breath, only 100 ml, not 1000 ml, 100 ml with each breath. His minute ventilation is going to be
1000.
100, yes, 100 into 10. That's mean that the minute ventilation is equal in both of these cases. Okay. But in one case, the respiratory rate is higher and the tidal volume is going to be lower.
Low.
That's why the total height is going to be remain the same. Okay. That's the only possible way that the total height is going to be remain the same. And we can clearly see that the black box in the second table in the second table is larger. That means the dead space is higher. That when the dead space is higher, something is going to be shrink. And what is that? That is tidal volume. And if its tidal volume is shrinking and the minute ventilations are same, that means the respiratory rate is going to be high. Okay.
High. Mm-hmm.
Okay. Let's move on to the next question. Okay. We show the following changes have most likely occurred compared at the rest. Okay. 20-year-old professional athlete participates in a sport. Okay, now we have to tell what of the changes occur in a professional season athlete. Incrementally increasing after he pulses 90% of the maximum tendency. Okay, now we have to tell what changes are going to occur a, a during exercise, right? Okay, minute ventilation. During exercise, does the respiratory rate increases? Does the
Yes. Yes.
amount of
Yes.
air a person is taking within each minute is going to increase or decrease? It is going to
Increase.
increase.
Increase. Increase.
Okay,
FC.
so option A and E are not the right answer. Okay, okay. Mixed venous oxygen content. So during exercise, does your muscles consuming much more oxygen or less oxygen?
More oxygen.
More
More
oxygen.
oxygen. Okay, so that's mean your muscles and your tissues are going to extract much more oxygen from the arterial blood, and when that blood is going to convert into venous blood, he is going to have less oxygen. So the venous blood has going to have less oxygen, right or wrong?
Right.
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 Right,
Right.
right. Okay, that's mean option D is also incorrect, right? We are left with option B and C. Okay, now comes to the ventilation perfusion ratio. Okay, is the ventilation perfusion ratio is going to be improved or is it going to be less improved? What
Improve.
happens?
Increase.
Yes, okay.
Increase.
Improve.
Increase
Yes, why?
because
Increase.
minute ventilation is high.
Yeah.
Why it is going to be improved? What happens to the blood flow to the lungs?
Vasodilation
Blood
occurs.
flow also increases.
Blood flow.
Yes,
Blood flow.
perfusion is going to increase, ventilation is going to be improved. Your apex of the lungs, which has the highest ventilation perfusion mismatch, which is usually contribute highest in the ventilation perfusion mismatch, has a higher blood flow, higher ventilation, and his ventilation perfusion ratio is going to be improved, and due to which your overall lung ventilation perfusion ratio is going to improve. So the right answer is going to be C, right? Okay, let's see where it is written in your first aid. I think so. They have explained the effects of exercises. Okay, response to exercise. PVO2 is going to decrease due to oxygen, mixed venous oxygen is going to decrease due to oxygen consumption. Okay. Heart rate is going to increase. Okay, see this. Heart rate is going to increase. Systemic resistance is going to increase. Perfusion is going to increase. Q represent perfusion. Pulmonary blood flow improves. V over Q ratio from base to apex is now becomes much more uniform. Okay, it's going to much more uniform. Because why he use the specific word uniform? Because your central area of the lung has a very good ventilation perfusion ratio. Your apex of the
Doc,
lungs has less ventilation perfusion ratio. Okay, so it is going to become uniform. All of the areas now have an improved ventilation perfusion ratio. Okay, it is become much more uniform. Okay, and it is going to be improved. We are studying response to exercise. It is written on page number 688. Okay, let's begin. Okay.
685 also it's given, Doc. 685 under the BQ perfusion.
Yes, it is also written in the 685 in the VQ pathway as well. In zone 1 to 3, we will study that in the other part. That zone 2 has the highest ventilation perfusion ratio, 1, and zone 3 and zone 1 does not have an improved ventilation perfusion ratio. Okay, but it do get improved during exercise. Okay, okay, you can see with exercise, cardiac output, there is vasodilation of apical capillaries, and due to which VQ of the apical capillaries also approaches 1. Okay, remember this. Okay, let's move on to the next one. Let's see, is there anything in the explanation which people need to know? Okay, people already know that. Okay, let's move on to the next one. Which of the following best explain these respiratory gas findings? Okay, now we have to see, okay, what are the options? Venting and diffusion impairment. We need gas exchange in various physiology. Okay, can anyone point out what is the abnormal thing in this question? What is the abnormal finding in this question? And what should be the normal finding here?
Pulmonary venous O2.
Pulmonary
Venous.
venous PO2. What is the normal value?
35.
No, it
Pulmonary
should be
venous,
100,
yeah,
104.
yes. It should be 100, okay, or 104 you can say, but after the mixing of blood with bronchial vessels it decreases to 100, but it should be 104, right? Because when the pulmonary artery which carries the deoxygenated blood, it goes into the lungs, its partial pressure of oxygen becomes equals to the partial pressure of oxygen in the alveoli, okay, and it increases from 40 to 104, right, in normal case. But right now, it only increases up to 70. Okay. But you can clearly see that the carbon dioxide partial pressure, is it normal or is it also abnormal?
It's normal.
Yes, it is normal because pulmonary artery, a pulmonary artery pressure of carbon dioxide is 45. When it enters the lung, its pressure is 45. When it leaves the lung, its pressure is going to decrease to 40. Carbon dioxide pressure is normal, but why does not the oxygen pressure a, a become equal to the alveolar oxygen pressure and becomes 104? What's the cause here? He's asking us this specific question: why does not the blood does not become
Shunting,
oxygenated
So,
enough?
i-
shunting,
in case of shunting or the pulmonary embolism, as we have discussed in the previous question, as in the pulmonary embolism, the oxygen will not be, the blood will not be oxygenated.
Okay, okay,
I think
okay.
the
You
problem is
say
in diffusion.
Yeah, diffusion.
Diffusion.
Just by
okay, okay,
the
okay.
vessels.
Let's start with one topic. First, come to Sudesh. You people said that it can be pulmonary embolism. what happened to the carbon dioxide pressure in the pulmonary embolism? What happened to the carbon dioxide pressure?
Increase. Increase.
That
Eh,
is increased. Not
no, in pulmonary embolism, do we
Respiratory
hyperventilate or do we hyperventilate?
decreases.
Hyperventilate. Decreases the pressure of carbon
Yes,
dioxide. Yes.
and when you are going to hyperventilate, so your partial pressure of carbon dioxide should be decreased. But
Decrease.
here,
Yeah.
yeah,
yes,
but
yes.
here it is normal. It is 40. So there is no abnormal. So it is cannot be pulmonary embolism. Okay, okay.
Yes.
So we are sure that it is not option number C, right? It cannot be option number C. Okay. So we are. It cannot be faulting as well. Okay. 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 Now comes now whether it can be poor alveolar ventilation.
It's
Okay. If it is poor alveolar ventilation, poor alveolar ventilation means that less air is entering inside your lungs. So that's mean the alveolar PO2 is should be decreased, right? But alveolar PO2 is normal here. It is 104. It is normal. If it is alveolar hypoventilation, then option PO2 should not be normal in the alveoli, right? Right? Because if you're taking in less air, the alveolar partial pressure of oxygen in the alveolar air should be less. It is common sense. Okay, but it is not less, it is normal here. That means that the process of taking in the air is not damaged in any way. Okay, so option number E cannot also explain these findings. Okay, so we are only left with diffusion impairment. Let's see whether diffusion impairment is the right answer or the wrong answer. Diffusion impairment is the right answer, and it is a very difficult question, this one. Okay, so why diffusion impairment is the answer? Okay, for this, we have to open page number. Okay. Okay. Oxygen diffuses slowly while carbon dioxide diffuses very rapidly across the pulmonary membranes. Okay. So whenever you will see any pathology which is affecting the diffusion capacity in emphysema, whenever you see a case of emphysema, the first finding is always hypoxemia. You will never see hypercapnia first. In advanced cases of in very advanced diseases of emphysema, you are going to see you are going to see a hypercapnia. Okay, in very advanced, if you see a patient of emphysema and that patient has hypercapnia, you should that means that the patient disease is at its last stage. Okay, because the carbon dioxide does not depends on the diffusion capacity as much as the oxygen depends. Oxygen needs time. Okay, and if anything is going to affect the diffusion rate, like if the surface rate is if the surface area available for diffusion gets less, or if the uh, the alveolar capillary membrane gets fibrosed and it gets thickened. Okay, if any such thing happens, because oxygen requires time, that's why the hypoxemia symptoms always appear first, and carbon dioxide because carbon dioxide takes only 1 second. Is compare I will give you an example. See, in suppose that in the alveolar, the blood remains in the alveoli only for 10 seconds. Okay, and oxygen requires 8 seconds to become it to completely take the oxygen from the alveoli into the blood. It requires 8 seconds. The carbon dioxide only require 1 second to expel to expel the excess carbon dioxide from the blood into the alveoli. It only requires 1 second, but the oxygen requires 8 seconds. If the total amount of time in which the blood remains in the alveoli is 10 seconds. Okay, so if anything is going to decrease the time period, like if the time period decreases from 10 to 70, if from 10 second to 7 second, okay, now you are going to see hypoxemia. The blood will not be sufficiently oxygenated. Okay, but carbon dioxide will be sufficiently eliminated. Okay, but if the time decreases from 10 to 0.5 second, now you are going to see hypercapnia symptoms as well. Okay, so that's why the answer is diffusion impairment. Okay, diffusion limited oxygen and carbon monoxide. It is not carbon dioxide, it is carbon monoxide. That's why we use the term DLCO, because because carbon monoxide is used to measure the diffusion capacity. Okay, and DLCO is a term which is used to refer the capacity of any entity. Okay,
Can you tell us a page, please?
it is on page number 684. And you can also see this graph as well. Okay, the if it is perfusion limited, it becomes like, if it is diffusion limited, the blue line, you can see the blue line of PaO2. It does not become, PaO2 does not become equal to P capital AO2. P capital A represent alveolar air oxygen. It does not become equal to the alveolar air oxygen, which is normally 104. And it will stuck a little behind 104. And in this case, it should be 10, and in this case, it is 70. Okay. So it is this thing. I'm talking about this thing. Okay. The blue line is a little below the pink line, which is the normal line. Okay. 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 Let's move on to the next question. Okay. Let me show you this diagram as well. Okay. So see these partial pressures. Okay. When the venous blood enters, oxygen partial pressure is 40 and the carbon dioxide is 45. And when they are leaving, usually the PaO2 should be 104 and PaCO2 should be 40. PaCO2 is normal here, but PaO2 is 70 here, which shouldn't be, which is an abnormal finding. Okay. Okay, let's move on to the next one. Which of the following is the primary cause of hypoxemia in this patient? Okay, let's see the options. Alveolar hypoventilation, okay, and oxygen carrying capacity. Okay, now see the options. First, try to find each and every abnormal finding, and then try to see which one is going to be the which option is going to correctly explain all the findings. Okay, so have you read all the question? Have you read the whole question?
Yes.
Okay,
Yes.
so okay, so what do you think is the diagnosis in this question?
Pulmonary
Diagnosis.
embolism.
It's
Fat
fat embolism. Fat
embolism.
Fat
embolism. Yeah.
Yes,
embolism.
yes, yes, yes. Fat embolism is a type of pulmonary embolism. Okay, so let's see each and every finding which we are seeing in this question. First, shortness of breath and hypoxemia, which are consistent with pulmonary embolism. Anyway, now comes to the risk factors. Admitted 3 days after a motor vehicle collision. Evaluation revealed a femur fracture. Remember, fat embolism occurs only after long bone fractures, long bone and pelvis fracture. Only these two bones. Like if you have a fracture of your finger bone or any other small bone, you will not have fat embolism. Okay, only long bone fractures and pelvic bones. The patient has a femur fracture. Okay, and underwent open reduction internal the motion experienced shortness of breath, sudden onset dyspnea, and sharp chest pain due to it is a pleuritic chest pain. Okay, okay, is smoked a cigarette, Pulse is 98. Blood pressure is normal. Chest X-ray is normal. pH is patient is in
Acidosis.
High.
That's high.
alkalosis. Alkalosis. Okay.
Alkalosis.
Alkalosis. Carbon
Yes.
dioxide is less. Why the carbon
Yes.
dioxide is less?
Because
Because
Hyperventilation.
hyperventilating.
Respiratory closes. Yeah.
Yeah, because the patient is hyperventilating.
Hyperventilating.
Okay,
Yes.
and hypoxemia. Okay, so everything can be explained by pulmonary embolism. Each and everything is like, okay. Now comes to the answer. Which one is going to be the right answer?
Ventilation. VQ
Perfusion
mismatch.
mismatch.
E.
Ventilation perfusion
Mhm.
mismatch.
Yes, ventilation perfusion mismatch. Okay, we have just studied this in a previous question as well, that it is going to increase the physiological dead space and it is going to increase the VQ mismatch. Okay, 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 let's move on to the next. Which of the following most likely accounts for the difference between these two parameters? Dead space, volume, functional residue capacity, residue volume, respiratory rate, and okay. Okay. Yes. Okay. Okay. So basically, in this question, he is asking us that the patient minute ventilation is 6 liter per minute. Minute ventilation means that the amount of air that the person is taking inside its lungs is 6 liter. Okay. But the alveolar ventilation is 4.2 liter per minute. There is a difference of 1.8 liter.
Dead
Okay.
space.
Okay.
That's space,
Why
yes.
there is a difference of 1.8 liter in this question? That's the thing that the examiner is trying to ask us. Okay. Okay. What is alveolar ventilation? Can anyone tell me what is alveolar ventilation?
Ventilation
And
at the level of alveoli.
The
The,
yes.
the gases,
Okay.
yes, reach to the
Yes.
alveoli.
Yes. So alveolar ventilation is only that air which is in the alveoli. Okay. So not every air which you are taking in is going to be in your alveoli. Some of your air is going to be in your mouth. Some of your air is going to be in your trachea. Some of your air is going to be in the primary bronchus. Okay. The air which is in your trachea, is it going to take part in the gaseous exchange?
No.
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 Yes, it is not going to take part in the gaseous exchange. The air in your primary bronchus, is that going to take part in your in the gaseous exchange? No.
No.
The air
No.
in your nose, mouth, pharynx, is
No.
that air is going to, yes, that is
No.
also not going
Anatomic
to
dead
take part.
space.
Yes. So all of these things, that difference is the dead space area. Okay, so the right answer is going to be the dead space volume. Yes. Anatomic dead space of conducting airways plus alveolar dead space. Usually, the alveolar dead space is zero. Usually, only the anatomic dead space is equal to physiological dead space. Apex of the healthy lungs is the largest contributor to the alveolar dead space because the highest area at which the VQ mismatch is in the apex area. Remember this too. Okay. Dead space is the volume of the air that does not take part in the gaseous exchange. Okay. Physiological dead space is approximately equivalent to the anatomical dead space in a normal people because in normal people, there is no concept of alveolar dead space. Alveolar dead space concept arises during pulmonary embolism or shunting during that. Okay. Okay. Let's move on to the next one. Which of the following is the most likely cause of this patient's symptoms? Which of the following is the most likely cause of this patient's symptoms? Okay, now start reading from top onwards. Okay. Emergency button after being stuck in the malfunctioning elevator for 45 minutes. She felt extremely anxious in a closed space within an and experienced dizziness, shortness of breath, generalized weakness, blurred vision. Okay, she has no other medical condition. Age is 32. Takes no medication. Does not use tobacco, alcohol, or illicit drugs. Okay, what is going to be the diagnosis here?
Yeah, here's
This
the
panic
panic
attack
attacks.
due to the claustrophobia, you know,
And
she's
claustrophobia.
Yeah, the patient is it is a typical case of panic attack. Okay, he is stuck in an elevator. She is claustrophobic, and due to which she is now showing the signs and symptoms of panic attack. Do we hypoventilate or hyperventilate during panic attack?
Hyperventilation.
Hyperventilation.
Hyperventilate. Okay. So if you are hyperventilating, what will happen to your oxygen levels?
Carbon dioxide decreased and respiratory
And
oxygen
alkalosis.
will be okay, but
yes,
people
oxygen
watch
is
out
going to be
about carbon dioxide,
yes, oxygen is going to be
hypocapnia.
okay. Yes. Oxygen is going to be okay. That means B, T, and E is not the answer. Okay, so we are left with A and C, and carbon dioxide level are going to decrease. And
Decrease.
and we will develop acidosis or alkalosis.
Respiratory
Alkalosis.
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 Alkalosis. The option number C is also not there. Arterial lactic acid cannot be there.
A is the
So
answer.
option number A is the
Yeah.
right answer.
Yeah.
Let's move on to the. Is a panic attack, hypoxic ventilation, hyperventilating. Okay, let's move on to the next one. Okay. Which of the following most likely explain the change in the partial pressure indicated by the area? Okay, what are the options? Increased dead space ventilation, diffusion limited oxygenation. Okay, limited shift in the solution. Oh, okay, can anyone explain what he's trying to ask us in this specific question? Can anyone explain this? What is he's trying to ask us in this specific question? Okay, so I will let you know what he's trying to ask. So in venous blood, on y-axis, what is on the y-axis? Partial pressure of oxygen. In venous blood, the partial pressure of oxygen is 40. Okay, it is 40. In the alveolary capillary blood, the partial pressure becomes equals to the alveolar oxygen partial pressure. Okay, because of the diffusion, the diffusion will continue as long as the partial pressure becomes equal, right? Okay, when the partial pressure becomes equal in the alveoli and in the blood, the oxygen will no longer move from one area to the other. In the alveoli, the partial pressure is 104. So the partial pressure in the blood of the oxygen becomes 104. Okay, so now he is asking when in the arterial blood, when you measure the partial pressure of oxygen in the arterial blood, the partial pressure is not 104. There is a slight dip in here. It is
You're asking about
100.
shunting.
There is a slight dip in there, only a slight dip, not a very large dip, only a slight dip from 104 to 100. Why?
I think it's a mixing.
Shunting is, you know, there is some bronchial blood supply
Yeah.
also. There is just 3 to 5%, you know, the blood shunting that decrease the PO2 in the pulmonary veins.
I think it's
Okay.
the mixing of blood because of all the upper pole of the pulmonary is different with the
Okay,
lower pole.
So do you people know what who supply blood to the cells of the alveoli? Who supply blood to the lung tissue? Pulmonary
Bronchial arteries.
Bronchial artery.
yes, pulmonary
Bronchial.
artery does
Pulmonary artery.
not pulmonary artery does not supply blood to the alveolar cells, to the whole of the lung parenchyma and tissue. It is only involved in the gaseous exchange part. The alveolars, the whole of the lung tissue does not take its glucose and its oxygen from the pulmonary artery. It is only there for gaseous exchange. Okay? It does not take glucose from there. It does not take nutrients from there. Okay? The main blood supply is bronchial vessels. Okay? So, because bronchial vessels only carry a very tiny amount of blood as compared to the pulmonary artery, right? Okay, they're going to carry only like they only carry like 2 to 5% of the blood, of the whole blood, which is moving inside the pulmonary trunk. Okay, so when that blood, after supplying whole of the lungs, will become after it's going to supplying whole of the lung tissue, the bronchial vessels becomes deoxygenated. The blood going to become deoxygenated, right? And that blood is going to be mixed with the pulmonary artery blood. Okay, and because that blood is very small as compared to the pulmonary artery blood, you will see only a slight dip. Okay, now you understand why you will see a partial pressure of 100 instead of 104, and why that dip is only very small, very tiny one. Okay, now you understand why we see that small dip.
Yes.
Okay, now when you have understand all of this concept, what do you think should be the right answer?
C.
The
I,
C mixed with the deoxygenated blood.
And that
Bronchial.
deoxygenated blood is coming from where?
This
Bronchial.
bronchial
bronchial
blood
arteries.
source.
Okay. See this photo. In the artery, there is 40 and carbon dioxide pressure 47, and the PaO2 becomes 104. But when it is reaching at the pulmonary veins level, it is 100. Can you people see this? It decreases
Yes.
from 104 to 100. Why? Because of the mixing of deoxygenated bronchial blood.
Doctor, I have a doubt. Can I ask?
Yes.
Why was it not A, diffusion limitation? Will there be a large drops if it was A?
Yes, if it is a because diffusion limited oxygenation happens in where? Emphysema. Emphysema is a classical example of option number A because
Mm-hmm.
there is the surface area is dropped now. Now we are going to see a much larger drop there. Okay. The
Okay, okay.
and in the question, a 24-year-old
Okay,
healthy
got
college
it.
student, in the
Got it.
top he has mentioned that the case we are studying in this is a healthy student. The patient is not suffering from any kind of pathology here. Okay,
Got it. Thank you. Thank you.
let's move on to the next one. An increase in which of the following is expected. The peak of this is equation. Mm. So it is again question regarding exercise, how exercise affects our uh, carbon dioxide and oxygen levels in our blood. So during the peak of exercise, what will happen to the oxygen level and to the carbon dioxide level and to the pH and everything? He is asking about that. Okay, the carbon dioxide level, is it going to increase or is it going to decrease?
Increase.
In
Increase in the
is
vein.
yeah, increase
Increase.
in the venous blood.
Venous
Okay,
blood.
not yes, not in the arterial, not in the arterial blood. We have also seen this in our each number exercise changes. Yeah. PvO2 is going to decrease. PvCO2 is going to increase due to carbon dioxide production. Okay, it is written here. Okay, it is going to increase. Okay. Okay, venous blood mean oxygen carbon dioxide is going to increase. Venous blood mean oxygen content is going to decrease. Okay, physiologic dead space is going to decrease. pH of the arterial blood is going to slightly normal. Hemoglobin affinity decrease. Arterial blood mean oxygen content. It has nothing to do with that. Okay, so the right answer is CF. Okay, let's move on to the next one. That question. Okay, this one is a difficult one. Let's see.
The answer is the A, the COPD patient. They provide the oxygen.
Why the answer is A? Why it is not central chemoreceptors? Why?
Said that yeah, the in COPD patients, most of the primary is the central chemoreceptors. They are more sensitive to the carbon side, but in COPD patient, there is decreased sensitization of the central system, and the respiratory drives go dependent on the periphery carotid bodies, means on the hypoxia.
Okay,
When
let's
we
first try to explain the question. It is a 56-year-old man comes due to chronic cough, fatigue, stress, cyanosis, experience, long term is okay. So most likely this patient is suffering from COPD. Okay,
yes,
so he's saying that during evaluation, is when we give the patient long term oxygen therapy, his respiratory decreases shortly after he begins nasal cannular oxygen supplementation. The thing he's trying to ask, why the respiratory rate decreases when you start the oxygen in the patient. And we know that the main centers which controls the respiratory rate are the central receptors, right? And those
yes,
receptors are regulated by carbon dioxide. The they are regulated by the pH, by the hydrogen ions, and the carbon dioxide. The main regulator of the respiratory drive is carbon dioxide. We know that. Okay, it is an established fact. But why? And oxygen is a very minor contributor. Okay, so but what is happening here? Okay, that when you have a long-standing hypercapnia, your receptors become like they become adapt to that. They no longer respond to that stimuli. Okay, so but if you give the other minor stimuli, then they are going to respond to that. Okay, because carbon dioxide, it is a long-standing chronic cough towards since age 18. Since age 18. Okay, because he has a long-standing history of COPD, and due to which his central receptors now becomes adapt to the carbon dioxide levels, and they are no longer responding to the carbon dioxide levels. Okay, and usually oxygen is not the main contributor to the respiratory drive, but in this specific scenario, only in this specific scenario, oxygen is the main major contributor. And we know oxygen acts on which receptors? On the peripheral receptors. And where are these peripheral receptors? In the carotid bodies. Okay, not in the kidneys, not the pulmonary C fibers, not the pulmonary stretch fibers, in the carotid bodies. Okay, central receptors respond only to carbon dioxide. Okay, so the right answer is carotid bodies. Okay, decrease in respiratory rate. Let me see where it is written in the first read. I don't remember where it is written.
In the CVS portion.
Yeah, in cardiovascular.
Yeah, it is written in the cardiovascular, right? I should. Can anyone tell me the page number? I think so. I should go to the CVS section. Cardiovascular. Yeah, here it is written. Carotid sinus baroreceptor, carotid ventricular peripheral receptors. Okay, you can see the carotid and aortic are stimulated by PaCO2 and PaO2. And see, central are stimulated, the central ones are stimulated by pH and PCO2. Okay, do not directly respond to the PO2. That's why option number B is not the right answer here, because it is clearly mentioned in the question that the respiratory drop is due to oxygen, not due to carbon dioxide. Immediately after starting the nasal cannular oxygen, there's a drop in the respiratory rate. And we know that the central receptors do not respond to the oxygen levels, only the peripheral ones. And what are the peripheral ones? The carotid one. Carotid also respond to the carbon dioxide levels. But along with carbon dioxide, they also respond with to oxygen levels as well. Okay. So is it clear now? Why the answer is not B and is it A? Is it clear now?
Yes.
Yes.
Okay. Because we in this case specifically are talking about carotid bodies only about oxygen only, not carbon dioxide. Okay. That's why most of the people select option number B. 51% of people select option number B. Okay. Because this specific scenario is explained in CVS instead of pulmonology. That's also one reason. Okay. Now comes to this, which are the first. Okay. Okay, first we have to diagnose the patient. Okay, so can anyone tell me all the abnormal findings in this patient? All the abnormal findings. Sudden onset shortness of breath. Okay, sudden onset shortness of breath. Crush injury after motorcycle drove over his left foot, and he has been immobilized.
Pulmonary
Since
embolism.
yes, he has been
Pulmonary
immobilized.
embolism.
Temperature. What is the respiratory rate?
It's high.
28.
Tachypnea.
Even tachypnea and tachycardia as well.
Mhm.
Okay, lungs are clear to auscultation. Dorsum is swelling compared to the dorsum of the left foot has dissolving ecchymosis and swelling compared to the right calf. The right calf is swollen and tender. Okay. Why the right calf is swollen and tender?
DVT developed.
Because of block.
DVT development.
DVT. Mhm.
And
BMI 37.
what is the cause of DVT here?
Immobilization.
Immobilization because of
Yes,
surgery.
it is
Immobilization.
immobilization, not the crush injury. It is immobilization, and due to the pulmonary embolism, now the patient has. Okay, now comes to the answer.
Respiratory
PO2. Are
disease.
we going to see hypoxemia or hyperexemia? Oxygen
Hyper-
levels.
Respiratory alkalosis. Yeah.
How
High.
close is?
Oxygen should be normal.
Should be
Uh,
high.
okay, pH should be high. So option A, B, and C are eliminated.
So
Oxygen levels should be
Or we can go for CO2 because of the low CO2, you know. Hyper.
yeah, okay.
Yeah.
Oxygen level should be less or high.
less.
So
Less.
Less.
Mm,
Okay. Carbon dioxide level
Low.
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 Degree.
low. So the only option left is option number C.
D.
Option number D. Sorry. Option number D. Oh, I don't know why a lot of people get this question wrong. Okay, let's move on to the next one. Which of the following best explain these patients' laboratory findings? Okay. Okay, now first see all the abnormal things here and then try to make a diagnosis which can explain all the abnormal findings in this patient. Okay. Okay, can anyone explain to tell me all the abnormal findings? Only the abnormal ones here in this question and don't skip any abnormal finding. Let's start with mild dyspnea and fatigue. Chronic fatigue and mild dyspnea. Mind seems foggy all the time and is not able to think clearly. Okay. No significant past medical history, does not take any medication, lives in a risk factor, sedentary lifestyle. Okay. Smokes a half pack of cigarettes a day for 5 years. For 5 years, that doesn't count as a risk factor. Okay. Some type of hypertension as well. BMI is increased. Chest X-ray normal. Partial pressure of oxygen is reduced. Carbon dioxide is elevated. And the alveolar arterial gradient is normal. Okay. And the alveolar, any diagnosis?
COPD.
COPD, yeah.
No, it is
No,
not
no COPD.
COPD.
These are
No,
normal
Obesity
chest
okay, see,
X-ray.
if you are
Obesity
saying
related
COPD,
hypoventilation or
Hypoventilation.
yeah, if it is
Look like
COPD, the
sleepy
patient
chain
has only
syndrome.
a smoking history for 5 years. He
yeah.
has only a smoking history of 5 years, and you are seeing
Yes. Yes.
hypercapnia here.
Mm,
See
Yeah.
hypercapnia in very late stages.
mm,
And the other thing, AA gradient,
mhm.
that is normal also here.
Normal. Yeah.
Okay. And how are you going to explain the hypertension here? How are you going to that explain that hypertension?
Smoking
Okay.
Because of
history.
retention
And
of the
how,
CO2.
yes.
Yes.
And how are you going to explain the foggy, his mind seems foggy and he's not able to think clearly and the fatigue?
Like obstructive sleep apnea, the people in the
Yeah,
daytimes,
the
Yeah.
diagnosis, yes, the
Yes.
diagnosis
They
is
feel foggy
obstructive.
and yes.
Yes. Okay. Now open page number. Open page number. There it is. It is. Okay. Okay. First, please see this line. Altered respiratory mechanism with normal DLCO and normal AA gradient. Normal AA gradient. This includes respiratory muscle weakness, polio, myasthenia gravis, any disease which is not affecting the lung parenchyma directly. You are going to see normal AA gradient. Okay? Chest wall scoliosis and severe abnormality. Okay, so in severe obesity, you are going to see normal AA gradient. And in our case, the AA gradient is normal. Okay, now comes to the obesity hypoventilation. Here it is obesity hypoventilation syndrome. Here it is. Okay, sleep apnea, systemic hypertension. Okay, remember this? Nocturnal hypoxemia leads to systemic and pulmonary hypertension. And in our case, we are seeing there's a hypertension as well. Repeated cessation of breath, daytime daytime somnolence. The patient feels foggy in our case. Okay, comes here. PO2 is usually normal, associated with obesity. The BMI in our case is 32, which is high, and daytime sleepiness. Okay, okay. And in obesity hypoventilation syndrome, the PO2 is going to be low and PaCO2 should be high. Okay, okay. So
If
now
there is
each,
right-sided hypertrophy, then is Pickwickian syndrome also. Mostly they develop late.
okay. So now each and every possible thing, each and every abnormality and the risk factor now is making sense, right? Okay. So what will be the answer if the answer it is a obesity is obesity hypoventilation syndrome? What should be the answer then?
Chronic hypo.
Chronic
Chronic
hyperventilation.
hyperventilation.
Yes, chronic hyperventilation because option number B, it does not affect the lung diffusion capacity. It does not affect because the main pathology here that the patient has large amount of tissue in its neck area, which is obstructing the trachea, due to which less amount of air is moving inside the lung. It is not affecting at any point the alveolar capillary membrane interface, right? So it is not lung diffusing capacity. It is not causing destruction of lung parenchyma. It is not affecting the lung compliance. It is not increasing the tissue oxygen consumption. It is not acting as a shunt. Chronic hyperventilation. Okay, let's move on to the next one. Okay, so which of the following pathway fluid turnover is most likely to be observed?
Sorry, somebody's mic is open, so there is a lot of noise. Would you please turn off your mic? Thank you.
Dr. Nahi, please turn off your mic.
Okay, so physiology is studying the mechanism of pleural fluid formation and they are obtained healthy elemental animals with anatomy fluids and those channels are injected into this and eliminated which tries to flow into and out of the pleural fluid space. Okay. Okay, can anyone tell me where does the pleural effusion develops? At what area? Pleural effusion develops at what location?
In pleural space
In pleural space.
between the visceral and the parietal pleura.
Pleural. And where does the pulmonary edema develops?
That develops in the alveoli.
That develops in the alveoli. Remember
Alveoli.
this difference. Okay. So it develops in the pleural membrane. Okay. So does can you tell me the who is going to supply the blood to the pleural vessels? Is it going to be intercostal vessels or is it going to be the bronchial vessels?
Intercostal.
Intercostal vessels.
Yes,
Intercostal.
yeah. The pleura is going to be supplied by the intercostal vessels. Okay, and bronchial vessels are going to supply the lung parenchyma.
Lung
Okay,
parenchyma.
okay. So option A and option B are not going to be the answer, right? So we are left with option C and option number D, right? Because we know that pleural effusion develops where? Between parietal pleura and the visceral pleura, right? So now comes to how is going the fluid is going to exit. Okay, is it going to be acted through capillaries or is it going to exit through the lymphatics?
Lymphatics.
Where
Lymphatics.
Lymphatic.
where
Through lymphatic.
where pulmonary capillaries are located where?
They're in lungs.
Yep.
Comes around the
They're at
alveoli.
Around the
pleura.
alveoli.
Yes, they are around the alveoli. They are not in the pleura membrane. So how are they are going to remove the excess fluid when there is a pulmonary effusion there? That is going to be removed through the lymphatics. That's why in one type of pleural effusion, there is a type of pleural effusion we call is chylothorax. Okay, what happens in chylothorax? There is obstruction of lymphatic duct. Remember, yesterday we solved a question.
Thoracic damage.
Yesterday we solved a question when there is the thoracic duct is damaged. And when the thoracic duct is damaged, we see pleural effusion. Why this pleural effusion when the thoracic duct is damaged? That means there is some relation between the lymphatics and the pleural effusion. Lymphatics are the main channels which are removing the fluids out from the when a pleural effusion develops. That's why when the thoracic duct, which is the main exit channel for the lymph fluid, when that is damaged, you will see pleural effusion, right? It also explained that question we solved yesterday in which there is a surgery in the neck area and then the person develop pleural effusion. Okay. So the right answer is C.
C.
Okay. Let's move on to the next question. Mm. Okay, so
Here,
have you people get the question?
yes, the patient is
Yes.
having the recurrent chest infections, indicating that the patient having and the younger age group, all going in the favor of
Younger age group, yeah,
yeah,
yes. And
recurrent pneumonias, and the sweat chloride contents are high,
high sweat
and
Cystic
chloride
also there is
contents.
the genetic
cystic
mutation in
fibrosis.
the
Fibrosis.
yeah,
Cystic
so it is
fibrosis.
Cystic
for cystic
fibrosis.
fibrosis,
Yes,
and
cystic fibrosis. So remember that cystic fibrosis is written in the biochemistry section, and you are
Yeah.
going to see a lot of question during solving the pulmonology blocks. Okay, like you are going to see almost 10 to 15 questions regarding cystic fibrosis. So do prepare cystic fibrosis. It is not written in the pulmonology section. It is written in extreme details in the biochemistry section. Okay,
mm,
so
Mhm.
okay, the first thing in this patient, 3 years of age, the age. Second, recurrent chest infections. Okay.
mhm,
Fourth thing, high sweat chloride content. This is very specific for cystic fibrosis. You can explain recurrent chest infections with any other disease, but you cannot explain high sweat chloride content with any other disease. Okay, the test for the diagnostic test for the cystic fibrosis, the name of that test is sweat chloride test. Okay, so this test is very specific for cystic fibrosis. Now, now he is asking us what type of mutation and what type of receptor that is get mutated in. Okay, let's open cystic fibrosis. It is in. Okay, so this is cystic fibrosis. Okay, so you can see the complications, recurrent pulmonary infections. Okay, recurrent pulmonary infections we see in cystic fibrosis. Other than that, okay, cystic fibrosis encodes an ATP-gated
chloride.
chloride channel, which secrete the chloride in lungs, GI tract, and reabsorb the chloride in sweat. That in the sweat. Remember this: the in sweat glands, you are going to see highest chloride secretion, and in the GI tract, in the mucus glands, you are going to see less chloride secretion. Okay, see this in sweat eyes because in cystic in sweat ducts that channel is involved in the reabsorption of sodium chloride, and in airway or in GI tract it is involved in the secretion, And when that the channel is not present, you will no longer be able to secrete the chloride. And so you are going to see low chloride content in the airways and high chloride content in the sweat. Remember this. Sometimes they trick you with this. Okay? Okay? High chloride only in sweat glands, not in GI tract or in airway. In there, you will going to see low chloride. Remember, this is a very important difference, and they are going to trick you with this.
Dr.
Okay?
Hassan, please repeat it once again.
What are you saying?
Please repeat this once again.
Okay. So I am saying that in sweat duct, the channel, the chloride channel is used for the reabsorption of chloride. You can see here. Normal, the function of that channel is chloride reabsorption. So if the channel is we are talking about sweat duct. If the channel is not there, chloride is not going to be reabsorbed. Okay. So you are going to see high chloride outside the cell. Okay. Is it clear now? Is it clear up till now? Okay.
Yes.
Now comes to the airway. Okay. In airway, that channel is used for the secretion of chloride. Okay. So if that channel is no longer there, the cells are no longer able to secrete the chloride. So the chloride will be high inside the cell, not outside, inside the cell. Okay. So you will see low chloride content in the airway and in the GI tract. High chloride content is only seen in the is only be seen in the sweat ducts. Okay.
Got it.
Remember this difference. Okay. Okay. Let me see where there's mentioned the sweat chloride test. They should have mentioned somewhere here. Hypokalemia, included the cleans.
Excuse me, can a host remove this Dr. Nahid Amiri from meeting, please? Because this doctor is not listening.
Okay, let's get back to the question. Okay, so what type of channel is it going to be?
ATP gated.
Yes, ATP gated. Okay, wait. CFTR gates an ATP gated chloride channel. Okay, let's move that. Did anyone say something?
Yes, I said, can host remove Dr. Nahid Amiri from the meeting because this doctor is not listening, only disturbed section?
So I do not know how to remove someone from the lecture. It's been, I don't know because I am not the admin in this. Dr. Ahmed is. I don't know how to remove Dr.
Oh, she
Nahid here.
already muted the mic now. Thank you.
Here, Dr. Nahid has muted the mic. Okay, now continue to the next question. Okay, which of the following start from the last line? Which of the following mechanism is most likely responsible for clearing the foreign particles from this patient's respiratory duct? Okay, first try to diagnose the patient and then you will see which of the cells are going to be involved in this. Okay. The 45-year-old man, persistent cough, progressive dyspnea on exertion, no medical issues, but has been exposed to large quantities of coal dust while working as a miner for the past 15 years. Small nodular opacities in the upper lobe. Lung biopsy reveals fine carbon particles within the respiratory bronchioles. And so, what is the diagnosis here?
It's
Yes,
Co-worker. Oh my God.
coal-worker. It is pneumoconiosis and it is coal workers' lungs. Let me open page number. So I know most of the people know where it is written, poll workers,
696.
but this is
696.
important. Like I know most of students from you do know where it is written and everything like that, but there are students there which do need this. Okay, so because when they see that this is written within the first aid book, it will give them confidence. Okay, so now they know that this exam is doable for them. Okay, because everything is written within the first aid. Okay, okay. First thing that the coal affects the base. Base means the and but affects the roof. Okay, and whenever you will see a silica, coal, and berries are from the base, and but affects the roof. That's mean coal. You when see a coal lungs pneumoconiosis, you will see an upper lobe infiltration. In our case, small nodular opacity in the upper lobes. Okay. If it is asbestosis, then the lower lobe are going to be affected. Okay. Okay. Coal workers prolong coal dust exposure. Macrophages laden with carbon. Okay. Macrophages laden with carbon. What should be the answer here? What
D.
is the function of
Phagocytosis.
macrophages?
D.
Phagocytosis.
Phagocytosis.
Phagocytosis. D.
Because macrophages are involved in phagocytosis, and macrophages are the main one which are involved in coal workers' lung. Okay, phagocytosis. Okay, coal one inorganic dust, finest particles, inflammation, fibrosis, small minimum damaging, and I think so. It is also written in the anatomy section as well. Phagocytes की foreign material. What? Macroalveolar macrophages. Okay. Alveolar macrophages are involved in the phagocytosis of foreign material. And in this question, he is asking which of the following are directly involved for clearing the foreign particles. Okay, let's move on to the next one. Okay, each bar represents total lung capacity. So, which of the following lung volume pattern is most likely to be present in this patient? 64-year-old man. 40-pack years smoking history.
Look like B.
Hyperresonant on percussion, diffuse
Emphysema.
wheezing, flattened diaphragm, narrow mediastinum, and decreased bronchiovascular markings. What is the diagnosis here?
COPD.
COPD.
Emphysema.
COPD,
Emphysema.
emphysema, yes. Because on emphysema, you're going to see flattened diaphragm, narrow mediastinum, hyperinflation of lungs, hyperresonant. He's a 64-year, has the 40-pack years in smoking history, which is the biggest risk factor for emphysema. Let's see here. Emphysema. Okay. Uh, let's see if it is written something. Okay, so it is an obstructive lung disease, right? Right, it is an obstructive lung disease, right? Okay, this is the, so they have given us a normal curve and they have represented each curve represents the volumes. Okay, so the in obstructive lung disease, what happens to the total lung volume?
Increases.
Total lung capacity in the
Increases.
obstructive lung disease is going to increase, right? So, so the total height of the bar should be larger than the normal, right or wrong?
Yes, right.
Right.
Okay, so which bar's height is larger than the normal?
B
B
and
and C.
B and C.
B and
B
B
and
C.
and
C.
C.
Option A and option D are eliminated. Okay, now comes to option B and option C. So what is the difference between option B and option C? What is the
Residual
diffusion?
volume is
Residual
increased in
volume in
B
B
and
increasing
in
Yes,
now.
decrease.
yes. So the line which is indicating the maximal expiration is a little bit higher in option B. Okay, so that's mean even after maximal inspiration, a large amount of air is in patient B as compared to patient C. Okay, that's mean the residual volume is higher in option B, but in option C, the residual volume is the same as compared to normal. And we have seen that in obstructive lung disease, that the residual volume increases in obstructive lung disease, right? But in option D, C, the residual volume is the same as the normal, right? So the right answer is B,
B.
right? Okay. See, residual volume increases, and it is a COPD, typical case of COPD. Okay, let's move on to the next one. Which of the following is the most likely? Okay. Diagnosis. So in this question, the patient has a pleural effusion, right? So first we
Look
have to
like
find out.
pleural effusion in
A,
malignancy.
so yes. So what is the cause of that pleural effusion? Just a yields fluid present thoracentesis, yields fluid with large number of red blood cells and numerous atypical cells staining for positive for mucin. Okay, that's mean that it is adenocarcinoma most likely, because mucin is a marker for adenocarcinoma. Okay, so the pleural effusion is due to malignancy, and there is anorexia and unintentional weight loss as well, which is also showing that it is lung cancer. Okay, now you have to tell me, pleural effusion due to malignancy, is it going to be exudative or transudative?
Exudative.
Exudative.
Oxidative.
Exudative.
Okay. Okay. That's open. Okay. So, see, exudative causes infection, pneumonia, tuberculosis, malignancy, connective tissue disease, lymphatic chylothorax, trauma, often requires drainage. And what happens to the capillary permeability in the exudative? Vascular
Increase.
permeability, it
Increases.
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 And in transudative, what will happen? The hydrostatic pressure, either the hydrostatic pressure is going to increase or the oncotic pressure is going to decrease. Okay.
Mm.
And now we are sure that it is an exudative pleural effusion, right? Okay, now comes back to the question. Is option A is going to be the right answer? Option A.
No, no.
No,
Decreased plasma
it's
is
exudative.
Because decreased plasma
transudate.
oncotic pressure is transudative. We
Yes.
have just studied transudative has two reasons: decreased oncotic pressure and increased hydrostatic pressure. Okay. Is option C is going to be the right answer?
No.
No.
No. Option
No.
No.
number D, yes. And option number D?
Total pressure.
Oh, it's in heart failure. D is it will
It's
pulmonary capacity.
also
Yeah.
transitive.
Yes,
No.
Yes.
transudate.
Because whenever the hydrostatic pressure is going to be get elevated, the cause is going to be transudative. The effusion is going to be transudative. So C and D are not the right answer. Okay. Now we are left with option number B and option number E. Disruption of the thoracic lymphatic duct and occlusion of the pleural lymphatic stoma. Okay. Now you have to tell me which is going to be the right answer. Where
Look
is
like
the
E.
I
E.
think
E.
it's E because
E.
the
Like
cancer
Thoracic
E.
spread
duct
through
is in contact.
lymphatics. The
Yeah.
cancer
Occlusion
spread through
is
lymphatics.
Yes.
So According to
Why not?
location, the
Yeah,
adenocarcinomas are
yeah,
peripheral in location, so
yes.
the
Good,
peripheral
good, good.
lymphatic stem.
Very good. Because, but where's the location of the thoracic lymphatic duct? It is in the it is in at the neck area,
Neck
and
area,
we are
clavicle
talking.
area,
Yes, and
subclavian.
yes, and we are talking about a pleural effusion, which is located inside the lungs, right? So the most likely chance of the of thing which is going to get blocked
It's plural.
is the pleural lymphatic stomas, okay?
It's A.
Not the B. So it's the right answer is E. It is a malignant one, and it is going to occlude the malignant cells are going to occlude the lymphatics, because we have studied the exit area of the pleural effusion are the pleural lymphatics, right? And they are going to be get blocked, and due to which we are going to see exudative pleural effusion. Let's move on to the next one. Okay. Which of the following is the best estimate of the intrapleural pressure at the point marked by a black dot? Okay. If people can see the black dot on the blue line. Okay. Now see the options. +10, +5, 0, -5, -10. Okay. Okay. Now read the question. Okay. 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 So have you people read? All of you have read the question?
Yes.
Okay. So he is asking about the combined compliance at the point B. The pressure, best estimate of the which pressure? Intrapleural pressure. Okay. Can anyone tell me anything about intrapleural pressure? What do you people know about intrapleural pressure?
Intrapleural pressure normally is the -5 mmHg, and it is the pressure within the pleural space, which has the ability to prevent the collapsing or the atelectating ability of the lung. And
Yes. Okay. Okay. Open page number. So intrapleural, that means a pressure between the visual pleura and the parietal pleura. It connects the lungs. Visual pleura is connected with the lungs, and parietal pleura is connected with the chest wall. So it joins the lungs with the chest wall. So this pressure should always be negative. If a positive pressure develops here, it is going to press the lungs away from the chest wall, and it is going to cause the collapse of the lungs. Okay. Okay. See this diagram? Can you people see this diagram? Intrapleural pressure.
Yes.
See, the pressure is always in the negatives. It is -5, and at maximum it is -10. Okay. And so it is, but in during whole of the inspiration and expiration, it always remains negative. It never becomes positive. Okay. Remember this, because it can never become positive. Like, when it will become positive? When you will see pneumothorax.
Pneumothorax.
Okay, in pneumothorax, air move into the intrapleural space, and due to the air in the intrapleural space, a force develops there, and the pressure becomes positive. And what happens there? The lungs collapse. You are going to see atelectasis there. Okay, so remember, this pressure is always going to be negative. Intrapleural pressure, not alveolar pressure, not the lung, not the pressure within the lungs. Intrapleural. Okay. So +2 cannot be the answer, +5 cannot be the answer, 0 cannot be the answer, right? Now we are left with -5 and -10. Now tell me why it is not -10, or if you think it is -10, then why it is not -5? If you think it is -5, why don't you think it is -10? Which one is the right answer, -5 or -10? And why? Tell me the reason why.
I'm thinking of -10.
-5.
Minus
Why?
10.
Okay, you are thinking about
-5
minus.
because it's the minimum.
-5.
-5, the minimum.
Reason.
It's the minimum because -10 is maximum.
Okay.
Mm.
Okay. So in our case, what is the maximum intrapleural pressure? -8.
-8.
It is mentioned in the
-8.
question. It is mentioned in the question. The maximal, because at the end of, he has written at the end of maximal inspiration is -8.
Anna,
And, okay, now comes to the photo. See the dotted line? The dotted line in the center of this? That is the end of the inspiration and the start of expiration, right? The dotted line.
Yeah.
This dotted line. It is the end of inspiration and the start of expiration. And see, at the end of inspiration, the intrapleural pressure is highest. It's -8. It's highest at the end of inspiration and at the start of expiration. And he has told us that the end of inspiration, the pressure is -8. So whatever the pressure is, it should be less than -8 because it is the limit. -8 is the limit. Okay, the pressure should be less than -8. That's why -10 is not the answer here. The answer is -5. Okay. Did you able to understand what I'm trying to say? What I'm trying to convey to you people?
Yes.
Why it is
yes.
-5
Yes.
and yes.
Yes.
Okay.
No, please take it one more time.
Okay. So in the question, he has mentioned that the intrapleural pressure at the end of maximal inspiration is -8. Okay, -8, end of maximal inspiration. And in this graph, you can clearly see the dotted line is the line at which the inspiration ends and the expiration starts. Now comes to the intrapleural pressure. It is highest at the end of the inspiration. And in our question, what is the pressure at the end of inspiration? -8. That's mean -8 is the pressure here, X. Okay. So the pressure at the dotted line at this dot should be less than X. Whatever that pressure, it can be -2, 3, 4, 5, 6, but it cannot be greater than -8. Okay. So that's why the answer is -5. Am I clear?
Yes.
Okay,
Yes.
let's move on to the next question.
Yeah, thank you.
These are the following increased discussion. Okay. So on y-axis there are lung volumes and the t-axis there is the normal. Okay. So what type of disease is in this graph? Can you tell me what is
COPD.
happening?
Obstructive lung disease because higher
Yes.
blood
The
lung
COPD.
Physical
volumes.
volume seems to be
Yes, it is some kind of obstructive lung disease because the highest high of the blue line is higher than the black line, the highest high. Okay, that the highest high is higher than the black line. Okay, and the lowest low is also higher than the black line of the blue line. That's mean the highest high higher mean that the total lung capacity is higher in obstructive lung disease. In obstructive lung disease, total lung volume higher, or is it higher or lower? Total lung volume
Higher.
Higher.
high. Respiratory volume, is
Mhm.
it going to increase or decrease?
Increased.
Increase. Okay. Okay, now you have to tell me which one is going to increase in this patient.
Here,
Okay.
the residual volume is getting increased and the
Even.
lung capacity, E.
Residual volume over total lung capacity
Yeah,
ratio.
both.
Okay.
Total lung capacity also increases in this case.
Okay,
Yes.
they are asking ratio.
They are talking
Yes,
about the
They,
graph.
they're
yes,
asking
because
ratio.
the
They are
yeah,
asking
because
ratio.
yes, but the residual volume also increased in the COPD. Residual volume
Yes.
get increased, and the total lung capacity also get increased. Both
Yes.
values.
And you can see the difference. See the difference between this, the black line and the blue line here. Okay. So this
The
is the
peak.
increase. Yes, the peaks. See the difference here. And now compare this difference with this with this difference. And
Yes.
this difference is larger than that difference. This difference represents the difference of the residual volumes. Okay.
Yes.
And
Yes.
this difference represents the difference of the total lung volumes.
Lung
Total,
volumes.
yes. Okay. So
Mm.
that increase is larger than the other increase, right?
Yeah.
Both of them are increasing, but
Yeah.
but that increase is a larger increase as compared to that increase. So that's why, because in this residual volume is a numerator and the total lung capacity is a denominator in the ratio. Okay. And when the numerator is bigger than the denominator, then the overall number is going to increase.
Increased.
Okay. So E is the answer. So that doesn't mean that total lung capacity isn't increased. Total lung capacity do increase, but the residual in volume increase at a much higher level. Okay, you can see that these represent residual volume, these represent total lung capacity, and total lung capacity increases at a lesser rate as compared to the residual volume. Okay. Okay. I'm moving on to the next question. Okay. Which of the following is the most likely cause of this patient? The most frequent. Okay. Can anyone tell me the partial pressure of the pulse oximeter measures what type of oxygen in our blood?
The
Oxygen
oxygen attached with the hemoglobin. It's how
saturation.
the
It
hemoglobin is saturated.
measures the saturation. Pulse oximeter measures the saturation.
A pulse oximetry, does it measure the dissolved oxygen in the blood, or it measures the
Attached.
attached?
Attached with the hemoglobin.
Attached
Oxygen.
with hemoglobin, it actually measures the saturation.
Okay. Okay. Just give me a sec. Okay, open page number. Let's see if you people are right or wrong. Yes. Oh, here it is. Okay. Oximetry. Just give me a second. Okay. Just give me a second.
It's not written here, but yesterday Dr. Moa's lecture, he said this thing that pulse oximetry measures the saturation.
Pulse
Yeah, the
oximetry do
dissolved form of oxygen we measure only through the ABGs, where we can measure the saturation. The SpO2 is measure the how the oxygen is attached with the hemoglobin, how the hemoglobin is saturated with oxygen. The most of times now it is 100% now. But the partial pressure of oxygen means arterial is made by the ABGs. It's showing in millimeter of mercury, like it should be
yes.
100, yes, 104. And the saturation is oxygen, how attached the oxygen with the hemoglobin is 100% attached or 95%.
Yes, yes,
How
it
many?
do,
Yes.
yes, it do made the oxygen saturation, the amount of oxygen which is attached to the amount of oxygen which is attached to the uh,
Hemoglobin
hemoglobin. It does not make the dissolved oxygen. It will not give to the dissolved oxygen. But the total oxygen content
is the sum
depends
of both
upon
dissolved
oxygen.
and yes.
It depends upon two things: bound hemoglobin and oxygen solubilized in the plasma. Okay, and in this we can see that oxygen saturation is normal. The bound oxygen is normal, but the total is not normal. The
So the
total,
patient is having
That's
anemia here.
anemia, yes. That means other components, the most important component is hemoglobin. That
Yes.
also the part of total oxygen content.
yes, because you cannot explain the. So in this table,
But there's given the in anemia, the partial pressure of
yes,
saturation is normal and the partial pressure of oxygen also normal.
saturation is going to be normal.
Yeah,
Partial pressure is going to be normal.
normal. And total
Total
content.
oxidant is going to reduce. Why? Because it depends upon two things: oxygen bound to the hemoglobin. The if the hemoglobin is less in your blood, then the oxygen bound will also be less, right? But because the oximetry only measures the saturation, like if you like a normal person has 100 hemoglobin molecules, suppose this a normal person has 100 hemoglobin molecules, and if it's all 100 molecules are bound with 100 oxygen molecules, we are saying its oxygen saturation is 100%. Okay, now consider a person who has 50 hemoglobin molecules, but all 50 molecules are bound with oxygen. That means its saturation is 100%, right?
Yes.
Yes.
Saturation point of wise, it is 100%. All the 50 molecules are bound with oxygen, right? So pulse oximetry will show you 100%. Okay. But the problem here is he has 50 hemoglobin molecules inside. Not he does not have 100. Okay. And why he has 50? There's some type of blood loss or something like that. Okay. So that's why even when the oxygen saturation is normal, partial pressure is normal, even then the total is less. That can only be explained by one option here: chronic blood loss.
Chronic blood loss. Yeah.
Okay. Any other thing cannot explain that. Primary overproduction of polycythemia cannot explain that. Recent high altitude exposure will decrease the partial pressure of oxygen. So it cannot also be explained that. Right to left intrapulmonary shunting decrease the partial pressure of oxygen. But in our case, it is normal. Cyanide intoxication. In cyanide intoxication, the total arterial oxygen content is also going to be normal. In cyanide poisoning, all of this is going to be normal. So the answer is chronic blood loss. See, in cyanide poisoning, everything is going to be normal because cyanide acts at what area? At the electron transport chain inside the cell. It prevents the metabolism. It stops the use of oxygen. Okay. So it does not affect hemoglobin or any other thing. It affects the oxidative phosphorylation. It stops the use of oxygen in our cells. Okay. It blocks the cytochrome P5 complex. Okay. Okay. In polycythemia, oxygen content is going to be increased. Anemia is going to decrease. Cyanide, everything is going to be normal, and this is going to be high altitude. Let's move on to the next one. And it is explained on page number 687. Okay, here is the table. Okay, let's move on to 687. Compared to her physiological testing,
Doctor, please, after this question, can we take a 5 minutes break?
Okay, you people need breaks. Okay.
Like 5 minutes. And then we come back.
Okay. Okay, after this, we'll take a 5-minute break. Okay. Okay, so now in this question, he is asking us, how does aging affects our respiratory system? Okay, so you people tell me, during aging, a 70-year, which 20-year person lungs are more stiff, or the 70-year person lungs are going to be more stiff?
70.
70 years.
Yes.
With aging.
So yes.
With aging,
So
stiffness
with
increases.
aging, stiff, the 70-year person, the 70-year-old people will be going to have a much more stiffer lungs. That means they are much more difficult to stretch. That means the lung compliance is going to increase in them. Okay. Okay. Lung compliance is because now they become much more stiffer. Okay. Total respiratory system compliance. Okay. Okay. Now I will come to that. Okay. So there are two things. One is chest wall compliance and one is lung compliance. Okay. So the chest wall becomes much more stiff with aging or less stiff with aging?
Less.
More
More,
stiff for aging.
more stiff with it.
More stiff with aging. Lungs become less stiff with aging or more stiff with aging?
Less.
Does
I
the
think
lungs
Less.
are
less,
going
less.
That's stiff for
less? Yes,
aging.
yes.
Yes,
They are going to become much more elastic, but the
yes.
chest
They
wall
may be
is going
more
to become
compliant, but
yes. They are going to be much more compliant, but the chest wall is going to be much more much less compliant. Okay, to measure the total compliance, you have to add the compliance of chest wall plus lung. Now we have to see the difference, that which thing becomes much more stiffer as compared to the other one. Okay, so in which the difference is larger. Okay, if the difference is chest wall is going to be the larger, then the chest wall stiffness is the main factor who is going to decide the total lung compliance. Okay, if the difference in the lung compliance is higher, then it is going to be the main factor who is going to decide the total respiratory system compliance. Okay, so okay, let me open page number. I think it is written here something. See, you can see here. Lung compliance increases older adults. Okay, change in pressure is. See if it's written somewhere here.
and it is opposite in the neonates. Meaning neonates chest compliant is chest wall is compliant, but lungs are less compliant.
Yes. Maybe it is written
It's the
somewhere.
aging effect is given in the last page of journal pathology.
Yes, it is in
Yeah.
general pathology or general
Yeah.
pharmacology lab.
Mhm.
I think so. It is aging change. Let me see. It is written, if not general. Yeah, maybe let me see. It is not here. General path, right? Yeah, aging changes. Yeah, they are written. I know I've read them somewhere. They do add the aging changes somewhere.
The last page. Last page.
Mm.
227 of my book.
Aging changes. Okay. Lung compliance increases, chest wall compliance decreases. Chest wall compliance increase, stiff. See, okay, respiratory muscle fatigue, less vigorous. Okay, let's see the other options. Okay, lung compliance is going to increase. Option D is eliminated. Option E is eliminated. Option F is eliminated. Okay, physiological dead space. The dead space is going to increase or decrease in a 70-year person.
Increase.
Increase.
Increase. It
Increase.
is going to increase. Option number B is eliminated. Now we are left with option number A and C. Total respiratory system compliance. Okay, A and C. In one option that he is saying it is going to increase. Okay, so the main factor is the chest wall compliance. Okay, the change in chest wall becomes much more stiffer as compared to the decrease in as compared to the increase in compliance in the lungs do become elastic, but the change is not as big as compared to the change which occurs in the chest wall. Okay, so that's why the overall compliance decreases. Overall compliance is going to decrease. Okay, so the option C is the right answer. Okay, changes of aging, lung elastin decreases. So lung compliance increases, chest wall stiffness increases, diaphragm strength decreases, ventilator efficiency decreases, overall compliance increases. Remember, total compliance increases. Remember this specific difference. Okay. Okay, let's move on to the next question. Okay, wait. There's a graph here as well. Okay, see this graph. Oh, see, this is the graph we do in the previous question. Chest wall compliance, the lung compliance, and the blue line is the combined compliance. Okay. Okay, you could take a 5-minute break, then we will start
But sir,
at
they
10.
didn't mention something in age-related changes in this
Yeah,
graph, like silver hair, white hair, and 24 karat gold teeth, and precious stone in the kidneys.
is enrolled in the non-definition. Gradual loss of vertical kyphosis. These are the normal age changes, osteoporosis and the kyphosis. All of these are due to the
There are age-related changes.
age-related changes. But
Means
remember,
the
the the chest wall stiffness is a much more bigger factor in a normal person in determining the total compliance. It is a much more bigger factor as compared to the lung compliance. Okay,
So this is
and you are
affecting the chest wall then? The kyphosis and all is affecting the chest wall somehow?
yes, this is also somehow somewhat contributing the chest wall compliance as well. Yes, this is also somewhat contributing. Yes, you have mentioned this. This is also a reason that in
these are
this
all
specific.
these are all the symptoms with the passage of the time, with the age we can get. So we can
Okay.
if we have these symptoms in a patient, so we can conclude easily that they are asking about aging effect.
Yes, aging. Even if he hasn't mentioned kyphosis, even then the answer will be the same. Even if he hasn't mentioned the kyphosis, the answer will be the same. Okay. Okay, let's take a 5-minute break. We will start at 10:18. Okay. After at 18 minutes. Okay, at 18. At 19. Okay. Only a 5-minute break.
Session will continue for further 1 hour.
No,
Doctor,
we have only 45 minutes left.
45 minutes. Okay, thank you.
It is going to be a 3-hour session. Because I am not comfortable with taking a 1 hour session, because I do not think that taking a 1 hour session is any beneficial to the students. Be-
Absolutely.
Yeah, because in 1 hour you cannot teach the students whole U world, and U world is the most important thing in your step one journey. U world is the most important thing,
Yeah,
and
thanks
you
a
should
lot.
know each and every concept of the U world. Okay, and you
Mm.
should know how you can integrate your first aid with this. Okay, and you should also know that. And if you want to complete your U world within 3 months span, you should do a minimum of 40 questions each day, and for that you requires 3 to 4 hours each day. If you also
Correct.
do, yes, and if you also do the want to do the explanation with each question, okay, that was 3 to 4 hours each day. Okay, and in this, because in this way you will do 1200 questions in 1 month and 3600 questions in 3 months. So your whole you world with each and every question discussed will be done within a 3 month span. Okay.
Can I ask a question, please?
Yes.
So my question is that I wanted to ask, like, so UWorld people use it as a learning tool, right?
Yes.
My question is like, of course we cannot retain every information which is given in UWorld or in first aid. So my question is, just reading would retain information, or is there a way like we can retain information after
Okay, there's two things. There one
mhm
is the in solving a question there are two things. One
mhm
is knowledge.
mhm
You shouldn't have a knowledge gap. Okay, and the other
mhm
thing is your question solving technique. Okay,
mhm mhm
if you have only have knowledge and do not have question solving technique, if you have
mhm
absolute knowledge of everything, you can
mhm
even get your question 70% of times right. If you
mhm
have a good question technique and you do not have knowledge of, like,
mhm
use in the question they have mentioned some new pathology, but you
mhm
do not have the knowledge of that question, okay,
mhm
or you haven't studied that, but you have a good question solving technique, you can
mhm
still solve that question, still solve these questions with a 60% accuracy.
mhm
Okay.
mhm
Okay, so for knowledge you have to do repetition,
mhm
use Anki or use your first aid. First aid is a very high yield book. Is
mhm
each and every line is important. Okay,
right
and
mhm
after solving the U word, you get an idea which line is important. How you
mhm
should extract the information from the first aid. Now
mhm
you after solve, because if you start from first aid, you will never
mhm
able to know which line is important, which how
mhm
you should read, at
mhm
which topics are much more important as compared to the other ones.
mhm
But once
mhm
you do the U word, you get an idea, okay, this thing is important. This
mhm
information is much more important than the other thing. So they
mhm
ask questions in this way. Okay. So
mhm
you will
mhm
get an idea. Okay.
mhm
After that, when you read the first aid, that will be much more beneficial to you. Okay, work on your
mhm
knowledge, try to retain as much information as possible, try to
mhm
make connections, try to establish concepts. Okay,
mhm
and then you will able to see, okay, this cannot be, this sign and symptom cannot be explained by this pathology, this
mhm
cannot be explained by this pathology. And
mhm
then even when you have a 60% knowledge of an pathology, you can
mhm
still get the question right if you have
mhm
good concepts.
right.
Okay, and you
So
know how to solve a question.
right.
Okay.
I'm sorry, one more question before we leave. So let's say I'm doing CVS from first aid, right? So do you recommend or prefer doing the CVS from UWorld at the same time, like after,
Yes.
like, okay. So it goes
Yes.
side by side.
Yes, it goes side by side.
Okay.
Because if you're starting from zero, you
Yep.
will never able to know what is important in the first aid book. You will never able to know which
Exactly.
areas are much more important, where you should focus more.
Mm,
Because your 80% of your exam is going to come from 30% of the first aid. Only from
right.
the 30% of the diseases.
Mm,
80% of your questions are from the 30% of the diseases.
mm,
And the
mm,
remaining 20% is going to, from the remaining 70% of your first aid questions, from your 70% of your first aid topics. Okay.
mm,
So there
mm,
are some high yield topics, some are low yield topics. Low yield
mhm,
are also important. I'm not saying low yield are not important. Low yield are
mhm,
also important, because
mhm.
in the end you are going to give step two, and you all people want higher marks in step two. And
Right.
in step two, every MCQs is important, whether it is low yield or high yield.
Right.
You should put much more focus on the high yield ones, but you cannot get the low yield ones wrong as well. So you should have a
Exactly.
strong base.
Yeah. Also, I'm so sorry
Doctor,
for asking too many questions. So let's say I work full-time job, right? Um, do you think like with for 6 months, I know it's not a relevant question over here, but still I wanted to ask this question because a lot of us are working and studying at the same time. I don't know how many people are from America and how many people are from like different countries, but in America, of course, we have to work in order to support ourselves financially. Like with a full-time job, let's say if we're working 3 days a week or 5 days a week, do you think it's still possible to do like within 6 months? Step one.
It depends on various factors. First of
Mm-hmm.
all, your baseline. How
Right.
strong is your baseline?
Mm-hmm.
Okay, like if you give one block of NBME, how
Mm-hmm.
much score will you give? How much score will you get in that NBME? That will
Okay.
decide your baseline. Okay, like
Mm-hmm.
if you are getting 50% in your baseline,
Mm-hmm.
so that's mean you only need to give 4 hours a day. In
Mm-hmm.
four hours, only 4 hours a day,
Mm-hmm.
for 6 months or 3 to 4 months, and you will be able to get USMLE step one pass easily because you need to only pass this exam. But don't
Exactly.
try. Okay, but I will recommend don't try to gain 250s in your NBMEs. It will help you a lot in your step two. And step
Mm-hmm.
two is the main deal. You cannot afford to score less in step two. Okay.
Mm-hmm.
So because now your match depends on your step two scores. And your step two depends on in your step two, the
Yeah.
question is going to remain the same. They are
Mm-hmm.
going to add only one more line. What is
Mm-hmm.
going to be the next line of management? What is
Right.
going to be the best diagnostic test? What is
Mm-hmm.
going to be the best confirmatory test?
Mm-hmm.
The whole of the question is going to remain the same. They will
Mm-hmm.
only add these 2 3 words in it. Okay.
Mm-hmm. Thank you so
So
much, doctor. Mm-hmm.
okay.
Doctor, I'm sorry. Would the MBNA, the thing that you just explained, does it apply to MBNA exam?
NBM, I don't get your question. What are you trying to ask?
Because no, because you were talking about USMLE.
Yes.
Because with the MBNA, I see that they ask little things that it's not like it's in the U world. So I
A
was just
real exam is much easier than U one. If you are
Mm.
getting a higher score in U world, you will definitely get much higher score in your real deal. U
Okay.
world is much more tougher than the as compared to the real exam.
Mm-hmm.
Okay.
Okay. Okay.
Mhm.
Just after
Thank you
two
so
minutes,
much.
we are going to start after 2 minutes. Okay. A break for 2 minutes. Okay.
Thanks.
Great. Let's start. So, am I sharing my screen or not? Yes. Okay, let's start. Class, are you there?
Yes.
Okay.
Yes.
Okay, let's start. Okay. A 30-year-old woman who normally resides in Florida plans to travel for to La Paz, Bolivia, elevation 336 feet for a week-long business travel immersion. Which of the following physiological changes are going to? So he's asking us what type of changes are we going to see in altitude, how our respiratory system is going to respond to altitude. Okay. Okay. So what will happen to the oxygen level at higher altitude? Is it
Reduced.
going to, is it
Increase.
going to reduce? Okay. When there's less air in the at higher altitude, less oxygen will reach to your cells. How your cardiac system is going to respond to that? Is it
Second,
going to increase its cardiac output or not?
increase.
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 Increase to compensate for the lower oxygen. So it can oxygenate the blood at a much higher rate. Okay. So cardiac output is going to be increase. Okay. Okay. What will happen to the pulmonary arterial? Okay. What will happen to the plasma volume? We are left with only option B and C. The plasma volume. At higher
Re-
altitude, what will happen to the hemoglobin? Does
Hemoglobin
we
Increase.
increase? The body will
increases,
start
Increase.
erythropoiesis.
plasma
Yes.
increases,
So as the
Increase.
blood cells are going to increase, the
mhm,
plasma volume is going to
decrease.
decrease. Okay, because it is the plasma volume is going to decrease as compared because the blood cells are going to increase. Okay, now comes to the arterial resistance. What will happen to the arterial resistance? Okay,
It will
Resistance will
increase due to
increase
hypoxia,
because of hypoxia,
response.
vasoconstriction
Yes.
develops, and because of
okay,
vasoconstriction, resistance increases.
okay. Remember this. There's only one area in our body at which when there is low oxygen there, that the vessels in that area are going to constrict, and that area is lungs. Okay,
Lung.
like if you're like if there's a less oxygen in your muscles, what will happen? The vessels are going to dilate so that they can provide much more oxygen to the muscles. Anywhere else in our body except lungs, if there's less oxygen, the vessels are going to dilate. Okay, but only in your lungs, if there is less oxygen is going to be there, the vessels are going to constrict. Okay, so they can pay so they can match the ventilation perfusion ratio, because if you give a high blood flow to an area which has less oxygen, the blood will not be much efficiently oxygenated. Okay, so your main goal should be to give higher blood flow to an area which has higher ventilation, right? So your blood will be much greater, much efficiently oxygenated. Okay. If a specific area, see, suppose your one lung is collapsed and your other lung is normal. If you give half your blood to your collapsed area, to your collapsed lung, so that's mean that that blood will not get oxygenated, right? Only the blood which that is going to the healthy normal lung will get oxygenated. So only 50% 50% blood is getting oxygenated. But if you constrict the blood to the collapsed lung, now more blood will flow to the normal healthy lung. Now more blood will get oxygenated, right? That's why vasoconstriction occurs in hypoxia, okay, in your lungs to have a better ventilation perfusion match. Okay, now open page number. Just come. response to higher altitude. Increase erythropoietin, increase hematocrit, increase hemoglobin. So the plasma volume is going to decrease. Chronic hypoxic pulmonary vasoconstriction. Due to hypoxia, due to less oxygen in the environment, we are going to see pulmonary vasoconstriction. And when there is vasoconstriction, there is hypertension. So the blood pressure is going to increase pulmonary vascular resistance and increase pulmonary hypertension. Okay, it is written on page number 688. Okay, response to high altitude. Okay, so the right answer is C, right? Let's move on to the next one. Which of the following sets of water blood pressure are most likely present in this film? So what is the diagnosis here?
Overdose of benzodiazepine, ketoplasma.
Okay.
Respiratory depression, central.
Yes, respiratory depression.
Okay, so what does
Hypoventilation.
benzo cause? Respiratory respiratory
Depression.
depression. And when there is respiratory depression, that means respiratory rate is going to decrease. You are going to take less oxygen inside your lungs. So what will happen to the oxygen? Is it going to increase, decrease, or is it going to be normal?
Decrease.
Is it going to be decreased because now there is less respiratory rate, less air is moving inside, and then less air is going to be go inside your blood. What will help? What will happen to the carbon dioxide levels?
It will increase.
It will increase. Why? Because your respiratory rate is now less. Benzo, when a person intoxicate itself with benzos, it is going to depress its respiratory brain centers. Okay. So now if a person is respirating at 3 breaths per minute, what will happen? The carbon dioxide levels are going to get elevated. So option A and option B are both eliminated. Now come to the alveolar arterial oxygen gradient. Now tell me, is it going to be normal, increased, or
Normal.
decreased?
Normal
Yeah.
because of
Normal.
hypoventilation.
Yeah.
Normal.
Yes. What is alveolar arterial oxygen gradient? It is the difference of the partial pressure of oxygen in the alveoli and in the blood. And that gradient depends upon the alveolar arterial surface, the alveolar capillary membrane surface interface. Okay. If the pathology is not affecting that interface, like in pulmonary fibrosis, that interface is going to be affected. In emphysema, it is going to be affected. If that interface is not going to be affected, then the alveolar arterial oxygen gradient is going to be remain normal. We see in the we solve a question of obesity hypoventilation syndrome, right?
Yes.
And in obesity hypoventilation syndrome, the alveolar arterial oxygen gradient is normal. Remember, and what is its value? 10. Okay. So option C and option D and option E are eliminated. What is the right answer?
D.
Option D,
D.
the right answer. Okay. It is going to be normal in CNS depression, diffusion limitation, emphysema, interstitial lung disease. A gradient is going to increase. In VQ mismatch, pulmonary embolism, pneumonia, ARDS. In all of these, it is also going to be increased. Remember this. If the lung structure is not getting affected directly, then A gradient is going to be normal. Okay, remember this. And the normal value is 10. Okay. This is written, we have studied the A gradient is also written. This is the A gradient formula. PaO2 minus PaO2. The capital A represents the alveolar air and the smaller a reveals the blood air. Okay, it is the partial pressure difference between both of these. Okay,
It will be normal in pulmonary hypertension also, doctor?
in pulmonary hypertension, no, it is going to be increased, slightly increased because the pulmonary vessels, if the pulmonary vessel size is going to increase, like because of the pulmonary hypertension, there is some type of fibrosis in the vessels, it can get increased in that. Slightly, only slightly, not very
Got it.
large.
Got it.
Okay,
Thank you.
but only very slightly. Okay, let's move on to the next question. Compared to 30, which of the following? Okay, again a question related regarding aging. With aging, the person is going to 80%, 80 years old man is an 80-year-old man is going to retain much larger carbon dioxide inside its body as compared to a 20-year-old kid. The
Yes.
retention of
Yes, you can say
yes,
yes.
yes.
Carbon
Yes.
retaining.
Carbon dioxide retention in our body is going to be increased with aging, right?
Yep, yep.
Yes.
Okay, okay. So let's see this how it is going to unfold. Okay, first come to the PaO2 because the PaO2 PaO2 is going to increase or decrease with aging.
I think it's
Amount of
It's
unchanged with age.
unchanged.
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 Changed. Yes,
Unchanged.
unchanged.
okay. So okay. Now I will tell you a fun fact. So our brain cells, uh, are sensitive to what? Are they sensitive to oxygen or are they sensitive to carbon dioxide?
Carbon
Carbon
dioxide.
dioxide.
Okay.
Carbon
So
dioxide.
so our brain first priority is going to be keeping the carbon dioxide levels unchanged or the oxygen levels unchanged.
Oxygen.
The oxygen level.
Our brain centers respond to carbon dioxide
Oxygen.
levels.
Oxygen. Sorry, carbon dioxide centrally.
Yeah.
Because retaining carbon
Carbon dioxide.
more.
Our body, yes, our body first responsibility would be to keep the carbon dioxide levels unchanged because carbon dioxide is very toxic to our brain. Okay, if you have a little bit higher carbon dioxide, the person will become lethargic, it will become dizzy. Okay, so the because our brain receptors are central brain receptors, the respiratory centers in our brain respond to what? Carbon dioxide levels. Okay, so the first thing they will try to do is to keep the carbon dioxide unchanged through some compensatory mechanisms. Our body has now less capacity to retain, has less capacity to eliminate the carbon dioxide, but our brain is trying to compensate for that, okay, through different mechanisms, okay, to keep our carbon dioxide levels unchanged, okay. So the carbon dioxide levels are going to be unchanged, and the oxygen levels, our brain can compromise on the oxygen level. Okay, when you may when okay, see, whenever you go into a hospital, have you ever seen a pulse oximetry of a 80-year old patient? It is never 99%.
Yes, it's
It is
96, 97%.
96, 95, 90.
Yeah.
Why? Because there's a less oxygen there. Whenever you go, next time when you go to a hospital, see the pulse oximetry of an old aged person. It will never be a 99. Okay, it will always be 95, 96, 94. Okay, because our body can compromise on lower oxygen, but it can never compromise on higher carbon dioxide levels. So it will use some compensatory mechanisms to eliminate the higher compensatory mechanism to the higher carbon dioxide. Okay, remember this thing. Okay, so option A eliminated, option B eliminated, option C eliminated, option D eliminated, and we are left with only one option, option E. Decrease, unchanged, and alveolar oxygen gradient is going to increase. Because with the passage of time, you are going to lose alveoli, and due to which the diffusion surface area available for the diffusion is going to decrease, right? And due to which the AA gradient is going to increase. Okay. Okay. Air space is going to increase, lower peak force, microatelectasis develop at the lung basis. We are going to see increased ventilation perfusion mismatch, which is going to increase the AA gradient. Ventilation, going to the next one. Okay, which of the following is the most likely acid-base status in this patient? Is the patient has acidosis or alkalosis?
Acidosis.
Acidosis, acidosis. Acidosis, option B, option D are eliminated. Is it respiratory acidosis or metabolic acidosis?
Respiratory.
Respiratory, because carbon
But
dioxide is very high.
Yes. Option
Respiratory.
A eliminated, option E eliminated. Left with C and F. Okay. What is the normal value of bicarb?
22 to 26,
22.
min 24.
26.
Is
Yeah,
normal.
it is, so it's bicarbonate value,
Normal.
bicarbs are normal.
Normal here.
If it is in compensation, if it is in compensation, what should be its value?
Increase.
It should increase. It should be
Yes.
increased.
Yes, it
Yeah.
should increase,
Yes.
right? So that's means there's no compensation here,
Mm.
right?
Yep.
So it is going to be uncompensated respiratory acidosis. Let's move on to the next one. So what is the diagnosis here?
Look like septic shock, you know.
Okay, what are the all the abnormal things here? Can anyone
The
do it?
first of all, these fever, confused, no lethargic patient, high temperature 39.4, blood pressure is very low, 74 over 46, and tachycardic also, 128.
Consolidation.
Yes, pneumonia just due to the sepsis,
Oxygen
septic
saturation is
shock.
also very low. Mm.
Yeah,
What type of shock it is?
septic shock.
Septic shock.
Septic
Yeah.
Septic
shock.
shock.
And what is the cause of this septic shock here?
Pneumonia.
Pneumonia.
Pneumonia, respiratory infection.
Yeah.
Okay, so when a person with septic shock comes to you, what type of fluids you give to a septic shock patient? Do you give isotonic fluids, hypotonic or hypertonic?
Isotonic.
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 Isotonic 0.4.
Okay, okay, isotonic. Now you have to tell me, is 0.45 saline is isotonic?
Hypotonic. This is
3%
half saline.
saline.
Yes.
Is
Hypertonic.
it hypertonic?
3% is hypertonic.
Hypertonic.
Hypertonic. Option number C. Is it
Or
isotonic?
hypotonic. Sodium
Is
is
it is
No.
it is hypotonic.
Slightly hypertonic, but
Hypo.
yeah,
Hypoton
decreased fluid.
Okay.
0.
Now, out of the remaining three options, which one?
Ringer lactate is the
Ringer
Ringer
isotonic.
lactate. Ringer
Ringer
lactate.
Yes,
lactate.
Yes.
Yeah,
Ringer lactate is the right answer.
right answer.
And other than ringer lactate, what other thing do we start in this
Normal
patient?
saline.
A
Normal saline.
Saline, yes. 0.9%.
yeah,
0.9%.
and other than fluids, what other thing we will give in this patient?
vasoconstrictors. Vasoconstrictors like norepinephrine.
And antibiotics
Dopamine.
as well.
Antibiotic
Antibiotics as
first,
well.
no, but first we have to give the fluid, then the antibiotic fluid, then the inotropes, not at the
Yes,
start.
yes. First antibiotics and fluids, then the inotrops. Okay, let's move on to the next one. Okay. Which of the following is most likely to be observed in this? Okay. Okay, so in this graph, there is a blood flow, there's VQ, and there's base and apex. The blood flow is higher at the base area or in the apex area?
Base.
The base
Base.
area.
Base.
Area.
Yes.
Okay.
Maximum
Base.
aesthetics.
Okay. Can you see this graph?
Yeah.
So
Yes.
there are three zones.
Yeah.
Zone 1 represent the apex, zone 3 represent the base. At zone 3, the perfusion has two arrows within. Okay. And at zone 1, the perfusion has two downside arrows within. Right? So what do we conclude from here? That base has higher perfusion than the apex, right? Right?
Correct.
Yes.
Yes.
And remember, this is true only when the person is upright.
Right.
Okay, when the person is standing, this is true only when, okay? And in our case, the patient is upright. Remember, this is very important. Sometimes they play the trick that they say the patient is laying down. Okay, the blood flow is higher in the low in the base because due to the gravity. Okay, the gravity helps the blood because heart is located in the center, and then the gravity will help the blood to move downward, and it will decrease. It is against the gravity to blood to move the blood upwards. Okay, so only in the upright position. So now we know that blood flow is higher in the base and less in the apex. So option A can be right, right?
Yeah.
See the see the red line.
Yes.
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 Option B cannot be the right answer, right?
Mm.
Option C can be the right answer. D can also be the right answer. E cannot be the right answer, right? Okay.
Yes.
Now we are left with A, C, and D. Now comes to the second part. VQ mismatch, VQ ratio. VQ ratio is higher where?
At
At the
apex.
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 The apex.
And is lower where? At the
Base.
base.
In
Base.
the base.
Now tell me which one should be. A VQ should be lower or higher at the base. It should be at base.
Lower.
VQ is
Lower.
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 Lower the base.
So
Lower.
option A. So can option A be the right answer?
No.
No.
No. No. Option A
No.
cannot
No.
be the right answer. Right?
Mm.
Okay.
Mm.
So option B we have already eliminated. Can option C be the right answer?
No.
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 Option
No.
D.
No.
No.
Because it is saying that the VQ is the same at the base and apex, and we know that it is not the same. So the right
Yeah.
answer is
D.
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 Yes,
D.
very
D.
good.
D.
D.
Very good. Let's move on to the next one. Which of the following is the most likely cause of patient's symptom? Okay. What are the abnormal things in this patient? He is unresponsive, and the patient was found unresponsive on the streets. Pulse is 72, blood pressure 108, unresponsive to verbal and tactile stimuli, but moves to deep sternal rub. Partial pressure is very less. The partial pressure of oxygen of the alveoli is also less. Can anyone tell me the AA gradient in this patient? AA gradient.
8.
Low.
Yes.
Eight.
AA
Normal.
gradient is
It's
8.
low.
That's normal.
And that means
Normal.
it is normal.
Hy- hypoventilating
Yes.
means.
So with it is normal, then that means impairment cannot be the right answer. Shunt cannot be the right answer, right? The only thing which can explain this
Is the
is option A.
A.
Alveolar.
Yes, above
Hypo.
ventilation, because in that way you have less air, less oxygen, partial pressure in the alveoli as well. Okay, because in this, remember in obesity hypoventilation syndrome, you have less partial pressure of oxygen in the blood as well in the alveoli, and you also see this same scenario in the benzodiazepine overdose as well. Okay, and both of their causes is alveolar hypoventilation. Let's move on to the next one. Let's see the options. Read the question. Okay, so this question is okay. So, any idea what's the diagnosis here?
It's the restricted lung pathology. 2, 3 things are here as the fine crackles are also going in the favor of restrictive pathology. Also, the diffuse reticular opacities on the chest X-ray also indicate that the patient having the restrictive lung pathology, and the pulmonary function test decreased FVC, and the ratio is getting increased. So, if the
Yes.
obstructive pathology, in that case, the ratio will not be increased, the ratio will always be decreased. But in the
Yes.
restrictive pathology, it can be normal or increased. So
Yes.
it is the restrictive lung pathology.
It is a restrictive lung disease, because we have seen
Mm.
that in restrictive lung disease,
Mhm.
the ratio is going to be higher. Okay,
Yeah.
FeV1 over FVC is going to be higher, and the other values are going to be low, and which is quite consistent with this specific scenario. We can see that the FVC is decreased, and FeV over FVC ratio is increased, which is consistent with restrictive lung disease. There's a fine crackles. There are dumpstick shaped fingers, diffuse reticular opacity. Okay, all of these are indicating towards a restrictive lung disease, and most probably that restrictive lung disease is a pulmonary fibrosis. Okay, so okay, so I have to explain you a concept. It should be this is idiopathic pulmonary fibrosis. The reticular opacities with traction bronchiectasis. Okay, what is traction bronchiectasis? So when because it affects the interstitium, the fibrosis occurs within the interstitium of the lung. It does not affect the alveoli. Okay, remember this. It affects the interstitium of the lung. Okay, what happens that the lungs, the interstitium gets fibrosed. Now, because it gets fibrosed, now it is difficult for the lungs to get collapsed. Now, imagine a person who is in a sticky jar. Everywhere there is a sticky gum. Okay, and is it difficult for the person to to move its leg in that area when everyone is attached to a gum?
Yes.
Okay, so this is what happening in the lung fibrosis. They, because the alveoli are kind of stick to the interstitium because of the fibrosis, they no longer can get fibrosed. They no longer can get, they can no longer get collapsed because there is a continuous pressure through the that fibrotic strings which is pulling the alveoli outside. Okay, there are strings in the interstitium which are attached to the alveoli, which are putting a constant pressure on those alveoli, which we called as traction. Okay, we get traction bronchiectasis. Okay, when we put the answer, they will show us a photo. Okay, so the answer for the supernormal expiratory flow rate is due to the radial traction on the bronchial valves because it keeps the bronchial valves always open. It is predisposed that the lungs expel the air at a much higher rate. They will show you a photo. See this photo. See, in this photo you can see the interstitial fibrosis is there. Okay, and due to which there is a traction is a pressure is applying on that the middle area bronchiole. Okay, which is keeping the bronchiole open. Okay, this is called traction bronchiectasis. Okay, there is one word mentioned in the first aid. It is traction bronchiectasis. It's a radial traction is keeping the bronchi open, due to which you will see a higher expiratory flow rate in this. Okay.
And the alveoli will be smaller as compared to normal.
Yes. Alveoli
Okay.
are a little bit smaller because now there's a fibrosis in the surrounding environment, which is occupying the area. Okay. Yes, no, we finished. This is the following period in this. So this is going to be our last question because the time is up.
Um,
Decompensated one.
Yes, because the first thing is the dyspnea, patient having the dyspnea and the hypertension, and the physical exams showing the inspiratory crackles means the pulmonary edema has been developed because of the heart failure. And the chest x-ray shows the pleural effusion. So it is the transudative type of pleural effusion which has been developed because of the heart failure. And so
Yes.
they are asking which of the following pleuropulmonary changes are seen. So
And
we
what
know
type of pleural effusion we see in heart
tra-
failure?
transudative.
Transudative.
Transudative. Okay, and you
Yeah.
have correctly mentioned all the signs which are indicating that this pleural effusion is due to heart failure. Is a 64-year-old man, worsening dyspnea on exertion for the past 3 months, no, had a non-productive cough but no chest pain, fever, or chills, diagnosed with hypertension several years ago, as hypertension, shows bilateral right side bilateral inspiratory crackles, as well as dullness to percussion. Okay. Okay. So in transudative, what will happen to the vascular permeability?
Normal, that will not be affected.
Okay.
And the vascular hydrostatic pressure will be increased.
So vascular permeability is not going to be affected, and the hydrostatic pressure is going to increase.
Increased.
It is going to see in transudative clear fluid due to increased hydrostatic pressure. Example, heart failure, sodium retention. Or it can be due to decrease oncotic pressure as well. Okay. Vascular permeability increases in exudative. Okay, it is going to be normal here. Hydrostatic pressure is going to be increased here. Oncotic pressure is going to be normal here, and the lymphatic flow is going to be increased. Okay, because lymphs are responsible for removing the excess fluid. Okay. Okay, so this is all for today. We are left with 4 questions of physiology. Hopefully, tomorrow either we will start with pathology and pathophysiology, or we'll see what will be tomorrow. Okay, let's see whether I will be able to continue to taking your classes or not. It depends on Dr. Ahmed whether he will be able to arrange the funds or not. Okay, class, this is all for today. Hopefully meet you tomorrow.
Thank
Thank
you.
you so
Okay, bye
much.
bye.
Thank you
Thank you
so
so
much.
much.
We appreciate
Sorry,
Okay,
it.
Dr.
bye bye.
Hussein.
Thank you so
Thank
much.
Thank you, doctor. Please, can you send us
Yes.
the QIDs?
Yes,
Okay,
can you send us a
okay.
QID?
I will ask Dr. Ahmed to send the
All
remaining
right.
questions to you.
All right. Thank
Okay,
you.
okay, okay, bye bye. Okay.